So now we are starting with our basic endoscopy workshop, and we will begin with the name of Allah, tilawat from Holy Quran.
بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
Now I request Professor Israrul Akhtur Saab for welcome address.
बिस्मिल्लाहिर्रहमानिर्रहीम. थैंक यू वेरी मच. आज हमारी तीसरी एंडोस्कोपिक वर्कशॉप है जी मेयो हॉस्पिटल में, और इसमें हम तकरीबन 12 केसेस कर रहे होंगे जी, और उसके अलावा एक छोटी सी प्रेजेंटेशन है, एक प्रेपरेशन पे है और दूसरी डिसइंफेक्शन पे है. इसके अलावा हैंड्स ऑन सिमुलेटर बेस एक प्रैक्टिस भी है जो पीजी ट्रेनिंग के लिए है, और इंशाल्लाह सारी कंक्लूजन हम कंक्लूड कर रहे होंगे सारी वर्कशॉप को अराउंड 2 PM. So I wish you all the best for a good learning experience. I welcome you all. I hope and pray it will be a good learning experience for all of us. Thank you very much.
Now we have first lecture by Dr. Junaid Mushtaq. He will be presenting on endoscope disinfection and reprocessing.
Assalamu alaikum. I'm Dr. Junaid, and I'm really grateful to Professor Israr and his team for inviting me here to give a brief talk on endoscopy and disinfection and reprocessing. I think it's a very important topic, and we're all using endoscopes from many years, and reprocessing is something we're all lagging behind. So I'll be discussing what's the evidence-based reprocessing of GI endoscopes, the latest ESGE and WHO cleaning and disinfection consensus statements. So this is a topic that is central to the patient safety, and nearly all the outbreaks are related to the endoscopes have been traced back to the failure of reprocessing rather than the manufacturing devices. So endoscopes, they are complex semi-critical devices with the long channels that needs to be brushed and cleaned thoroughly. And WHO and ESGE emphasize the manual cleaning is the most important step for the disinfection of endoscopes. Inadequate cleaning that results in an increased biofilm formation and compromise the disinfection of endoscopes. So outbreaks that have been linked to Pseudomonas and microbacteria have occurred due to inadequate reprocessing of endoscopes in our GI units. So Spalding classification, we're all familiar with. They're divided into the non-critical instruments, the things like pulse oximeter, blood pressure, cuff, electrodes, and mouth guards. They needs to be cleaned manually, and disinfection attaining at a level of at least bactericidal and urticidal activity. And this cleaning and low level of disinfection needs to be encountered for these objects. So we'll be primarily talking about semi-critical and the critical ones. Semi-criticals are the ones which GI endoscopes which needs high level of disinfection, and the steps needs to be ensured is the manual cleaning at the bedside immediately after the procedure by flushing and manually cleaning the tubes of the endoscopes, followed by reprocessing, which includes.
Our first case is Mr. A. He's 69 years old male, and he presented with dysphagia for solids and liquids for 1 year. Barium swallowed showed a corkscrew appearance of esophagus, which is characteristic of distal esophageal spasm. High resolution manometry findings are that patient is having raised integrated relaxation pressure with pan esophageal pressurization, and this is consistent with type 2 eclasia cardia. Now we are going to perform a diagnostic upper GI endoscopy in this patient. So as we can see, the barium swallow of this patient, this is a very characteristic picture of corkscrew esophagus, and I have manometry tracing as well, which is showing upper and lower esophageal got an increased integrated relaxation pressure. And you can see that there is a yellow uh, area which is indicating pressurization. So this is there is pan esophageal pressurization in almost all of the swallows, 100% swallows throughout the esophagus. So this HRM high resolution manometry is consistent with type 2 achalasia cardia. So Dr. Bilal.
So, as you have heard the history that this is uh, an elderly male who presented to us with dysphagia. So, whenever you have patients with dysphagia, we always suspect at this age that there may be some organic cause. So, we have to define whether this is esophageal dysphagia or oropharyngeal dysphagia. So, if patient is saying that this is food sticking in the chest on history, and it is for the solid and for liquid without any cough, so we suspect this is esophageal dysphagia. As rightly investigated that we go for the barium swallow. In barium swallow, you have seen the images that is showing contraction, or maybe this is a corkscrew like appearance. So corkscrew appearance generally it can occur in mainly motility disorders, like we can have hypercontractile esophagus or jackhammer esophagus, or sometime if it is a tertiary contraction against the resistance, then we can have these sort of symptoms. And as you have seen the manometry of these patients, generally manometry is the gold standard test to differentiate between jackhammer esophagus with achalasia. So in jackhammer esophagus, generally we have the motility, like the wave front is there. There's no absent peristalsis. But you have seen in this manometry, I think you are looking at the manometry images. If you look at the manometry image, there is no wave front. So whenever we don't have any wave front, it means we consider it as absent peristalsis. But in jackhammer esophagus or in hypercontractile esophagus, we have the motility. So there is a wave front. We can differentiate it primarily on the IRP. So if the patients have high IRP, it means that this is something related to lower esophageal sphincter. So it is the incomplete relaxation of the lower esophageal sphincter, supported with panesophageal pressurization. So I am still thinking of that this patient is suffering from achalasia rather than jackhammer esophagus. So to start with, if you are a beginner, so to start with, you should know about your equipment first. So you should be checking the equipment, that whether the suction is working, the air water channel is working or not. So you can check it. My assistant has already done it. So this is the scope. If you can see the scope, we are using CV 1500 system with HQ 190 scope. And these are the two buttons. If you look at the blue button, this is primarily for air water channel. If we place the finger over the this button, this hole, the air will go in. If I press it, the water will also, if you can see the jet, if it is visualized, so water will come out of the jet. The second button, which is the red button, and that is primarily for the suction. So if I press it, I will suction. That button is very important in this case as well. And if you look at the endoscope, we have these knobs, two knobs. One is the small knob, the big knob. Primarily, the big knob is very important because this is the primary knob which we usually using during our procedure for different maneuvering. If we go for the right and left movement, that we can do with our wrist movements. Like if you look at the scope, if our scope is in straight condition, if we just observe my left hand, if I move the hand, the wrist movement, there is a remarkable, or there is a significant movement at the scope. So this is right for right and left. Usually we use this movement. And secondly, while doing endoscopy, always keep your scope straight. So don't go for the looping, because if you loop the scope, the end movement will be reduced. Just look at the tip of the scope. My scope is looped, and if I move in at my wrist, the scope will be moving less. But if it is a straight scope, this will be a main movement. So our patient is sedated. We are using propofol. Propofol can be. So gently we lubricate our distal scope with the xylocaine gel. We are waiting for the sedation, and there are some prospect as far as the patient is concerned. So we should be knowing that for why we are doing endoscopy for this patient. As we know, the history shows that the patient is dysphagia, so we want to rule out any structural cause in this patient. And next is that we should know about the comorbids of this patient. We should have a good history of drug history of this patient, so that we can decide that what sort of anesthesia we give to these patients. So while intubation, straight up, must be. So I'm going along the tongue, you can see, and you are seeing my endoscopy image.
Yeah. Yes, we can see the endoscopic image
Okay,
of Bilal.
so at 6 o'clock position, we are seeing the uvula. When we cross the uvula slowly along the base of the tongue, we'll be seeing the epiglottis. And when we see at the epiglottis, we will pass through gently. Generally, it's the slow movements. So a little bit of section, and here we can see that there is we see the area epiglottis, and the above is the epiglottis, and you can see that there is some fluid coming out. So it means there is some food is in the, or some liquid content in the esophagus. So we go to the this side. This side is the left area epiglottic fold. This is the right epiglottic fold. Movement of the our big wheel, and slightly push the scope gently and do the upward movement, and we are in the esophagus. Now look at this esophagus. There is retained fluid in the esophagus, so be cautious, and tell your anesthetist that just slightly do the just prop up the patient 45 पे कर दें अगर हो सके. So I will be doing suction just to clear out the esophagus, and closely monitor. Just look at this esophagus. If you can see, there are it is a dilated esophagus as compared to the normal esophagus, and we are going in slowly, observing it, and we are looking at the esophagus closely. You can see there is contractions, but they are not symmetrical contraction if you normally observe in upper GI endoscopy. So we slowly go in, keep on suctioning, then insufflate, so that you can observe the thing. This is a dilated esophagus with contraction. I would say this is tertiary contraction. And look at this lower end of the esophagus. It is tight LES, and if we push in, there is slight resistance. So slight resistance, and now with slight resistance, generally we don't have feel resistance. This is the feeling which you have at lower end of the esophagus. So when you go into the esophagus, normally we go across the wall of the stomach. So at that point, just what you can do is just pull back and do a clockwise rotation, just a clockwise rotation, and you will see the body of the stomach. Just go in, closely observing, but generally I usually do that, I go for the duodenal examination first. But look at the esophagus, the pylorus. We are not clearly seeing the esophagus in this, the pylorus in this patient. So I just come back, I go in again. These are the erosions in the esophagus, in the sorry, in the body of the stomach, and we go in slowly, slowly. So there is something with the, I think, the esophagus as well. The patient is fine.
तो इसमें आइडली जो है वो
So generally, in the bulb, it's a difficult intubation because we are not clearly seeing the. It's just like a J-shaped stomach, and I have to move in and then observe that where is the pylorus. So there is something is wrong with the pylorus as well. There may be some external fixation. And now this is the duodenal mucosa. I just manipulate and I am in the, in fact, duodenum. But this is not normally happen in a normal endoscopy. So when we are in the descending duodenum, I will show you the maneuver when we do it. Generally in the distal duodenum, what we do is we have to reduce our scope because our scope is very much into the, it's looping along the greater curve. So we want to reduce the scope. So for reduction of the scope, you have to keep the big wheel towards you. You pull the wheel towards you, just do a clockwise rotation, and you will be moving forward easily. So in the duodenum, what we have to observe is the folds, the number of folds, and any inflammatory process over there. We want to see the number of folds, the serrations, and now usually we use underwater technique to look at the villus pattern as well. So while you are coming back, sometimes it do happen that you fall back immediately into the stomach. So the method is that you just keep on doing this upward downward movement slowly and just gently coming back, slowly come back and observe the duodenum in all quadrants. So we have the erosions over there. These are the fine erosions in the descending duodenum. So this is the duodenal cap, and again we fall back. I think there is something going on from the exterior side in this part of the stomach, like distal stomach. So we have to observe this as well. So sometimes there is some pathology, some fibrosis over there, because normally we see pylorus in the upward front, but in this case it's not in up front position. It is slightly at 6 o'clock downward, and there is an external ridge which is quite stiff ridge. So we need to investigate it by doing the CT of this patient so that we can observe that something something else is going on. So this is the duodenal cap. Again, it's not the normal maneuvering which we do, but if we go, and now this, you have just observed this, because this ridge is actually troubling me.
Uh, Dr. Bilal, can this have something to do with underlying achalasia?
Generally, less likely. Generally, there is no such condition which can, like, other thing which can be there is some fibrosis which can be observed in Chagas disease, but in Chagas generally the manometric findings would be absent peristalsis. There is no peristalsis in Chagas as well, and the lower esophageal sphincter is tight in that, and there can be some obstruction at the distal esophagus. So we have observed the body, and I want to see the fundus of this patient very closely. If you can see the fundus, there is small hiatus hernia. If you see, this ridge is absent, and if this is not lower esophageal sphincter, minded, so there is evidence of small hiatus as well, hiatus hernia as well. So there is opening, but beyond that, if you can see, there is no esophageal mucosa. The esophageal mucosa is distal. So in normal conditions, generally what we do is we examine the fundus and we examine the incisura area, because we usually miss the finding over there if we don't observe it closely. And in cases of achalasia, we usually want to rule out any pseudo tumor or any pseudo achalasia, any tumor around the cardia of the esophagus.
Dr. Bilal, there are multiple linear
The erosions are there.
erosions.
So these are there. These are there. So these are the erosions. Longitudinal erosions are there. So this might be something to do with this pathology. That
Ulceration as well.
yeah, you are right. Longitudinal ulcerations.
Biopsy.
Ideally, we have to take the biopsies. If you want, I can take it, but the main pathology is primarily the esophageal side, because patient mainly have the symptom over there. If you want, I can take the biopsy. Coming back to the lower end of the esophagus, I must say that whenever normally you are doing upper GI endoscopy, always spend time at lower end of the esophagus. While you are doing retroflexion, always insufflate it for at least 30 seconds and observe three things over there. One is the ridge around the scope or the lower end of the esophagus. If you want to see the hiatus like opening, you have to measure the distance or dia of the hiatus as well, because now in newer classification of hiatal hernia, generally this is previously we used Hill grade classification, but nowadays there is an advanced classification like
American
this is
Foregut Society classification.
so
of
that
lower
is
esophageal
AFS Hill grade classification, in which they have included the width of the hiatus as well.
size is also,
Yeah,
hiatus size
that
is
is
also
again
included.
very important.
LDF system.
Yeah. So just examine the lower end of the esophagus.
And do you measure the hiatal aperture on retroflex view or from front view?
It's usually on the retroflex view, because on the front view you will be measuring the length of the hiatus hernia, and in retroflex view you can estimate it, because you can estimate it by knowing the because your scope is almost 10 millimeter, so you can just estimate that whether one scope along this scope or two scope or three scope, so you can measure it, because more than 2 centimeter is significant hiatus hernia.
So Dr. Bilal, can you have achalasia cardia and hiatus hernia in same patient?
Yes, you can have, because there is nothing to do with the minded, because in diaphragmatic the hiatus is the opening, and LES is nothing to do in ecclesia. So LES is in fact augmenting the lower esophageal sphincter pressure. So in in ecclesia, generally the patients have uh, uh, problem with the primarily sphincter. It's not the hiatus opening. So we can have this hiatus with ecclesia. And thirdly, while doing endoscopic myotomy, we came to know that we can observe the hiatus in those patients, and we should be extra vigilant in patients who have hiatus with ecclesia, because while doing myotomy, sometimes we can cut the diaphragm muscle as well, and we can increase the problem post poem.
तो सर इसमें अब चॉइस क्या होगी, अब ट्रीटमेंट की अब क्या करेंगे?
Generally, if no comorbid is there, so I would be going preferably with the myotomy in this patient.
Yes. Without doing high resolution manometry,
They have done
can
the,
we assess this patient by doing endoscopy?
no, I think this is the patient in which we have tertiary contractions.
Yes.
We can suspect that this is
All because
ecclesia,
of
but
this pool and
and now look at this lower end of the esophagus is tightly closed, so we have a
tightly closed.
So any question?
So, preferable treatment in this patient will be poem.
Point.
Yeah. If there is no contraindication, I would say poem is the best option.
And
But before going
that,
for the poem, I must say that we should have a CT in this patient to rule out any other disease in the peritoneum.
And would you like to perform an US of lower esophageal sphincter?
Generally not. We don't want to perform because there is no external bulge. There is nothing wrong over there. But if the mucosa, overlying mucosa is perfectly fine. So generally EUS have no benefit. People use it for this experimental purposes or study purposes, because with EUS we can assess the thickness of the muscle, and EUS can help us in deciding the length of the myotomy as well. So generally in ecclesia the muscle is thick, and if the thickness and the normal esophagus, when they we can decide that how much length of myotomy we do in patients with ecclesia. So in EUS is this benefit is there, but otherwise for diagnostic purposes there is no role of EUS yet.
so can you explain the types of ecclesia 2 and 3 differentiation?
So generally in
manometry.
on manometry we can differentiate type 1, type 2 and type 3 ecclesia.
Yes.
If you have images in front of you, in this patient what we have seen is that there is thank you Ji. In this patient you have seen that there is an upper esophageal sphincter, there is a red lining, and there is a lower esophageal sphincter. These are known as pressure zones, and in between that pressure zone we can differentiate that what type of ecclesia in this it is. So generally after the swallow there is opening in the upper esophageal sphincter, so there is a gap in the upper pressure zone, and then there is, if there is no wave in between the upper and the lower esophagus, there is nothing, no color change, same color is there, we say this is absent peristalsis, and we label it as type 1 ecclesia. But if we ask the patient to swallow, there is opening of the upper esophageal sphincter, immediately there is a pan-esophageal redness from upper to lower end. This means that this patient is type 2 ecclesia. In type 3 ecclesia, generally in the upper segment we have a wave front, and then there is an abnormal pre-esophageal or premature contraction, or I must say that there is a spastic contraction. So, and the IRP would be high in all the cases. We can differentiate the type 3 ecclesia. The differential would be distal esophageal spasm versus pan distal esophageal span versus type 3 eclasia. So in type 3 eclasia, generally we have premature contraction. The DL, the distal latency, would be less than 4.5, and in but the IRP would be on the higher side. In DES, we have normal IRP, and the DL would be less than 4.5.
Sir,
Sir, I have a question.
one question more. If there is no facility for pouring, as you know, in most of the setups, can we do pneumatic?
Yeah, you have
Ecclesia.
the options which we have for these patients are that we can have pneumatic with balloon dilatation and Botox, obviously. And pneumatic balloon dilatation is it's always should be a graded pneumatic dilatation, because generally we go for a single dilatation and we observe the patient. So that is not true with eclasia. So we start with 30 millimeter, we increase it to 35 millimeter after 4 weeks. Then we, if the patient is not improved, we can go up to 40 millimeter. And for pneumatic dilatation, it is again important that your balloon should, the waist should be wide open for a complete dilatation. So generally, if you have a half-hearted attempt for dilating the lower esophageal sphincter, this would be failed dilatation.
Okay,
So
Dr. Bilal, we have a case for eclasia dilatation as well, and now a case on station
Thank you.
1 is also.
yeah, thank you.
Thank you.
Dr. Bilal, I have a question.
Number 1.
Sorry.
Can I have a question, please?
Yeah, yeah.
Okay, so I'm Dr. Usman. I'm Assistant Professor of Surgery from South Surgical Ward. I have a question that a whole of our discussion in this case was going around the achalasia. But the thing is, what we have learned and what we have seen, that the achalasia has a typical bird beak appearance in the barium swallow. But this patient doesn't have on the barium it was shown. It was not a bird beak on the barium, and it was more of a like a semi-nutcracker type esophagus in this patient. And if we are and related to this question, if we are planning for the poem in this patient, what we will do? We will go for the lower esophageal sphincter only, or we will go for the whole of the sphincter, whole of the muscular myotomy.
Generally, in type 2 eclasia, we extend our myotomy to almost 8 centimeter into the esophagus. Generally, people are now moving towards the smaller myotomies, but I usually perform a 10 centimeter myotomy, 2 centimeter beyond the lower esophageal sphincter, and then 8 centimeter above the lower esophageal sphincter, including the sphincter as well. So generally, we go with 10 centimeters.
Professor
And
Gyasa
keeping
wants
in
to
view,
comment.
keeping in view.
Go ahead. You want to say something?
And second thing is that if we want to, the second question is bird beak appearance. Generally, now barium is not a gold standard for diagnosis of eclasia cardia. So you have a gold standard test, and there is a combination. Sometimes we need combination of tests, like barium would help at certain time. The upper GI endoscopy would be helping us, and the HRM is still the gold standard in patients with eclasia.
The history also suggestive.
Yeah.
उसमें intermittent होगा, इसमें
Yeah.
continuous.
That is again important.
Professor
Thank you.
Gyasa wants to comment.
Yeah.
Now, when you talk of achalasia cardia, parents follow that we have grown up with still
Green
image. The classical bird beak appearance occurs only in those people who have got advanced disease.
Dr.
Otherwise,
Habib, please switch to room 1.
Imaging modality of the choice is time barium. That as the person starts swallowing the or starts taking the contrast, one has to have a video scanning imaging capturing, so that you should be able to see whether the barium goes down into the stomach in a time fashion within 5 seconds, 15 seconds, and then 30 seconds. Now, the clearance of the barium from the esophagus down to the stomach, that is important. And the gold standard remains the high resolution impedance manometry, not just the manometry, the classical, the previous one, the hydraulic catheter-based manometry. The things have moved on, and it is solid state-based catheter help high resolution impedance manometry. So based on high resolution impedance spirometry, we differentiate whether LES pressure is high and there's any muscle movement in these figures. If there's a muscle movement in these figures, then we have to differentiate whether there's a pan pressurization or there's segmental increase in the pressure. With a segmental increase in the pressure and high pressure zones, that is type 3 achalasia. With pan pressurization and high LES pressure, it's type 2. If there's a high LES pressure but no movement in the spheral body, it's type 1 achalasia. So that's how we differentiate between three. In type 1, theoretically, yes, pneumatic dilatation does work, but the word has moved on from pneumatic dilatation, considering that we need to have 3 dilatations. Each dilatation is going to cost substantially. You have to have imaging costs. Then the complication rate is roughly down to the tune of 5%. So word has moved on from this great dilatation and the risk of 5% complication to POEM procedure. Being a surgeon, you can debate that yes, we can go ahead with the Hellas myectomy. Hellas myectomy is good, but in Hellas myectomy, in type 1 achalasia, classical achalasia, it works equally well. It's just as good as POEM. But in type 2 and type 3 achalasia, Hellas myectomy results are inferior as compared to the POEM, because in POEM you can do a longer length of muscle cutting, and then as per the requirement of the pressure zones, you can cut the muscles, the pressure zones in type 3 achalasia in particular. And then there's an overlap between the type 3 and type 2 as well. So one has to be a little careful in interpreting the results.
Now we are moving to room number 1. Dr. Amir, please present the case.
Yes, can you hear me, sir?
Yes, we can hear you. I have displayed the slide.
Okay, sir. Sir, this is the patient Razia, 60 years old female, known case of CLD, presented to us with complaint of anemia. There is a history of 3 pent-up blood transfusion in last 2 months, and now on presentation HB is 10.8 and platelets are 84,000, and came to us. Then we did the endoscopy. On endoscopy, there were 3 columns of low-grade esophageal varices and multiple red spots in the antrum. So we are doing APC for GAVE.
Okay, thank you, Dr. Amir. We have initially done the survey, and we can see that my scope is in the esophagus, and we can appreciate small varices. So from the esophagus, we enter into the stomach, and we can see the changes of portal hypertensive gastropathy. We can see the fish skin appearance of mucosa with few red spots. There is no fundal varix. There is no fundal varix, but we can appreciate few red spots around the cardia. So these are the changes of portal hypertensive gastropathy. As we move our scope forward into the antrum, we can see multiple angioectasias, and through a few of them, they are oozing at the moment. Fortunately, she does not have many angioectasias inside the duodenum, but we can see few of those. So since she is coming to us with anemia, our main focus is to treat these gastric atelectasias. We all know that they are the cause of refractory anemia, and at times it becomes very difficult to eradicate these angioectasias. So we have the choice of doing the band ligation or we do the APC. So band ligation is relatively superior in terms of eradication of these atelectasias. But we do have a lot of experience of doing APC. If we do the APC, patient might need repeated sessions at time, which in case of band ligation, patient needs a few sessions. So regarding the current settings, since the antrum is a very thick wall stomach, roughly 5 to 6 millimeter wall thickness of muscle is there. So we are not very much worried about the current. Usually the current settings are 30 to 50 watts in antrum. And we can use different modes of APC. The latest machines of Arbe, they have different modes. This one is the older machine, and it has forced APC only. But the newer machines, they have the precise APC, forced APC, and pulsed APC. So we are using forced APC, and the current settings are at 50 watts. So someone can start at 30 watts and see the response if we can increase the current to the 50. So regarding the safety of APC, there is a black mark. For the beginner, it should be slightly outside the scope, so that if the patient accidentally have the retching and you are pressing the pedal, someone cannot burn the scope tip. So we start with the APC, and my probe is in the antrum. APC basically it's a non-touch technique, and we need to maintain a distance of 1 to 2 millimeter away from the mucosa. And to maintain this distance, sometimes we use distal attachment cap that keeps the mucosa away from the tip of the scope, and we don't need to repeatedly clean our probe. So we start from here.
This is a common problem that we see whenever we start organ, our vision goes. Yes, this is Hamad. How are you?
I'm good. How are you?
Yeah, not too bad. Thanks. Beautiful demonstration. So in which patient would you choose APC, and in which patient would you rather choose band ligation?
Okay, so band ligation is more appropriate for someone who has nodular gave.
Thank you very much. That was my pre-question. What are the types of gave? But you've already answered that.
Yes. So, but we have been doing the band ligation in non-nodular as well, and the results are really very promising. Patient hardly gets any trouble even if we do band ligation in this kind of scenario where we do not find much nodularity. So, if some center does not have the availability of APC, we can always do the band ligation.
I find it very quick, more helpful, easy.
Yes.
The patient has some pain though afterwards. What do you do for that?
So we can see that it's a non-touch technique of coagulation.
Beautiful cooking of the mucosa. So if you do the band ligation, what do you do for the pain, and do you worry about ulcers and bleeding from them?
So routinely these patients, they get PPI twice daily for maybe a couple of weeks, and for pain we need to give paracetamol and spasmolytics at times, and many of the patients they receive antibiotics as well, because sometimes they get fever, they get febrile after the band ligation. But these symptoms, they usually resolve in a couple of days. That is not a major issue. We hardly need any hospitalization for management of these things.
Dr. Gas, this. Can you hear me?
Yes, I can hear you.
Okay, so a couple of comments. On nodular gave, there is some data that after band ligation, PPIs actually increase the recurrence of nodular gave. So we, in our practice, we do not use PPI after band ligation for nodular gave. That's one comment. Secondly, although there is not much data yet, but anecdotally, we use RFA through the scope probe with a contact technique because it's much quicker and you have much more surface area that you can burn. Although there is not a whole lot data coming out, but for a bigger area of gave as well as for rave, the radiation proctitis, also we avoid APC and we're using the RFA through the scope probe. So those are my couple of comments.
Okay, right. So one important thing is that this argon gas is non-absorbable gas. So once we do the APC in antrum, the gas tends to accumulate inside the fundus. So after doing some APC, we need to decompress the stomach. Otherwise, the patient will be having pain and discomfort after the APC. In refractory cases, we have the experience of using hybrid APC, in which we inject the saline in the submucosa. We can use the high voltage like 100 watts of APC, and we can just burn the whole of the mucosa. So we have done few of the cases of hybrid APC, and the results are really promising.
Thanks for this comment, Gyas. I think you can read minds. I was about to ask you about the, argon, which needs suctioning every so often. Otherwise, we can run into troubles. So a parallel question about the same patient's management. Has the, option of transplant been considered for this patient at all? She's, maybe a candidate. The host team, not to you.
I think the patient has child class A cirrhosis.
Yes, sir.
Okay, so apart from recurrent anemia, she is otherwise doing fine. Well, we can consider the patient for liver transplantation if she develops progression of cirrhosis, or there is some strong indication for liver transplantation apart from this.
Very, very maybe to an extent a controversial area, but recurrent bleeding and anemia from a source for which we do not have a definitive treatment.
Exactly.
We could continue APCing or bending it and fibrose the stomach, but with the platelets of 50, that tells me portal hypertension is pretty strong. So if not explored already, I think that avenue should be explored for this patient's management as well.
So how many of you use the distal attachment cap for APC? I find it very helpful, very quick, and the problem of recurrent clogging of this probe is very less compared to
the distal attachment. I'm yet to see a case where I did not find the distal cap not useful. It's always useful for all sorts of endoscopic therapy. Very rarely although I don't use it routinely because we are not used to it, whenever I decide to use it, has always helped me. Not specifically for APC, but it can, it can stabilize the nearby mucosa. You can rub this, this cooked tissue alongside the, edge of the distal attachment rather than the scope, which is more, precious, if that makes sense. Definitely, we should use more and more of distal attachments. So then the question is that this is almost a flow rate, pan, gastric gave, approaching almost to the gastroesophageal junction when you showed us earlier. So when would you stop? How long would you carry on?
Okay, so we try to do as much as APC in one session, maybe in 15-20 minutes. And once we do the APC, we keep on following the patient hemoglobin, look for the melena. And if the hemoglobin remains stable, we usually do not recall the patient. So basically the repeated sessions of APC, they are dependent upon the symptomatology like recurrent anemia. So this is how we usually follow these patients. So after the APC, we keep a record of hemoglobin, and we ask the patient to repeat hemoglobin or report earlier if the patient has recurrent melena. And the follow-up session is usually after 2 to 3 weeks.
So there is an RB probe with a mobile ball at the end. I don't know how many of us are familiar with that. That's very helpful. One of my colleagues would like to comment on it. I really like it if I have that.
The radial
probe. I'm sure most of my colleagues have seen it. And actually, they're very, very helpful in a case like this because you can, yeah, you can just literally just swipe it around in a 360-degree manner, and it burns the whole area, and then you clean it. And the trouble is you have to clean it over and over again, and sometimes the ball gets detached, so then you have to take out another probe, which unfortunately costs a fortune in Pakistan, but it works. Works really, really well. I had a patient who had recurrent bleeding from her pylorus and D1. I did about 2 or 3 sessions on her, and then she developed pyloric stenosis. Then she went for dilatation. So that's the other sort of problem with it. I think important cause um, stenosis in long-term use. Any other comments?
The radial probe, when I mean it's like when you have tangential area, especially AVM or some other region, that helpful also.
So this probe is basically the front firing. Sometimes we need to have side firing probe or radial probe for difficult areas or large areas to be covered. So, but for antrum, usually the front firing works good.
Okay, sir, I have a question again from surgeon's point of view. We are doing it in a circular manner in the pre-pyloric area or in the pylorus area. So, what are the chances of getting fibrosis and stenosis at this point after this procedure?
So APC is superficial kind of burning. So there is hardly any damage to the muscularis. So there are very, very rare chances of having any deep injury to leading for this kind of stenosis, which is symptomatic. So we haven't ever seen such kind of complication of ये चल नहीं रहा.
Dr. Gyas, what is your end point of APC? When will you
Okay,
stop?
so I will be burning all the visible angioectasia, especially those which are closer to the antrum and they have the more density. And since the patient is comfortable, I will be burning these few areas which are left, and then I will just follow the hemoglobin of the patient, and will be asking the patient to report to the hospital if she has recurrent melena or shortness of breath or symptoms of anemia. So we have almost burned this area, and I think the few of areas they are left along the greater curve, and some here.
And I think that Dr. Shamail Zafar is also ready. He is doing band ligation. Can we
Sure.
switch to other room?
Yes, please.
Okay, next case is case number 3. Patient Niyamat, 47-year male, presented with upper GI bleed. Patient is a case of chronic SCV related DCLD. It's a follow-up case, and the last EGD were done on 24th of November. Now, Dr. Shumail will perform the procedure.
You can hear me now?
Yes, sir. We can hear you loud and clear.
So this is cirrhotic patient on whom we are going to perform an endoscopy because the patient had hematomesis and melena, and he had a previous endoscopic ligation done about a month back. So whenever patient is having hematomesis and melena, we have to perform an endoscopy, a full endoscopy, to look for any sinister pathology. He may have bled from any other lesion as well. There is possibility in addition to the varices. So we are in the esophagus. And I have with me Dr. Ibtisam Amjad and Dr. Ayub. These are the stigma of the previous banding. You can see the scarring at 6 o'clock. Dr. Sam, what are your comments about it?
Okay, we can see the stigmata of the last banding, and I believe that we can go a bit distal to this, the previous banding site and can band it because we still believe that there is red hue present in the remaining varices. What do you think, sir?
Yes, I think the varix which is present at 4 o'clock position that needs a banding.
Yes.
And similarly, the one which is present at 9 o'clock position. Dr. Ayub, what are your comments?
Yes, sure. I agree with your decision. Below the scar area, there's one is a large very stub possible, and two more as possible. We can proceed with the band ligation of the
So what about the classification? The classification of the varix is based upon the size of the varix. So
large varix and small varix. One third of the lumen and below one third small varix, and above the one third is a large varix. I think one varix is a large varix, and two more are the small but bendable varix, if possible.
मेरा शक्कर होना। So whenever we are performing an endoscopy, we have to look for the fundal varices as well, which may be concomitantly present. एयर भी देखना, एयर सही जा रही है। So in this patient, we don't see any varices present, the fundal varices. So we are going to focus on the esophageal varices alone. The duodenum is also normal. So these are medium to large size varices, Dr. Sam, Dr. Ayub. So medium to large size varices.
If the varices reduce, then when, but after band negation, if the column remains, then maybe we bend, apply band, maybe to stop above the scar also.
Okay. So the blood flow is from down upwards.
Don't go up.
So we are going to go as further as possible. ये मैं पकड़ लेता हूँ, आप खोलोगे? जरा थोड़ा वो भी दिखा देंगे ना? So we are going to look at the band ligator assembly. This is a Boston Scientific one, speed band, and we are going to show you how to deploy it. Everyone should be knowing by himself that how to deploy it.
The tip.
So this is the banding tip, still stabilized in the pack, and we are going to remove it. First, we have to we are going to put the assembly in. We have to apply the wheel in the biopsy forceps channel.
यहाँ एक गिरा निकाल.
So we have put a wire over here, and this is the wire over which we are going to apply the bands, and it will act by the tripwire mechanism. From here, I am going to rotate the wheel, and one band will come out of it.
you put the scope on the table, or you are more comfortable applying the band, making the set in your hand? What is the more comfortable? What is more comfortable to you?
It looks more easy if we place the endoscope on the table and then we put the assembly in. But I'm more used to it.
Yeah.
This shooter is a bit different from a side 6 shooter.
Yes, this one is different from side 6 shooter.
Boston shooter.
This is
It has got a single thread or single wire instead of two wires.
yeah.
So now I think everyone can see there are 7 bands. The blue colored band, these are rubber bands, which we are going to apply on the varix. After sucking inside the varix inside this hood, we are going to deploy the band from here. So we have to go as far as possible close to the lower esophageal sphincter. And now we know that the first varix which we are going to apply the band on is at 3 o'clock position. Using the suction button, we are going to suck the varix in, and now we are going to deploy the band.
Good one. Yeah.
ये काम इधर ही होना होता है.
It was a juicy varix.
Juice. Yes, sir. Travel mucosa.
Yeah.
Yes, sir. Mucosa travel है. Tortuous mucosa.
हाँ. So a little ooze of blood from the varix, the last one which we did, and now we are looking that with 2 bands applied, the other ones. So Professor Kashif is also here. Any comments, Professor Kashif, with your meta glasses?
Complete endoscopy before doing your EVBL.
Yes.
So we can't listen to Professor Kashif.
Yeah. I was just talking to Shumail. My comment is because you have to do the complete endoscopy before going for your therapeutic procedures like band ligation and things like that. And because this is mandatory, you can find some duodenal ulcers even in patient with chronic liver disease and with the esophageal varices, and that may be the cause of bleeding in these patients.
Okay.
Right, Dr. Kashif, we have done a previous full endoscopy and we have looked for the duodenal ulcer and also for any vascular ectasias. We have looked for the fundal varices as well.
Another comment from me, if I take the liberty of, it might have been said already, but please don't go crazy on putting as many bands as possible. Stay close to the gastroesophageal junction, put a few, and if you get enough decompression of the proximal varices, please bail out and come out.
Yes,
we don't have to put as many as possible up until the upper esophageal sphincter. We need to focus on the distal 5 centimeter. That's
Yes,
where the bleeding
very well
happens from.
said. We applied 2 bands, and by applying 2 bands, we can see the rest of the varices, they have disappeared. I have tried another one, but that has been dislodged because of the thick mucosa overlying. So with 2 bands, the procedure of EVBL, the second session, I think is over. Jeep Samsab.
When will you recall this patient, sir?
Repeat endoscopy.
Every 4 to 6 weeks until we see that there is no varix.
So next session will be after 4 to 6 weeks.
Yeah, 3 to 4 weeks is good enough because he has got medium to high grade varices. So one session is mandatory after this. But later on, there is a difference in practices. I usually do not call the patient frequently because sometimes patient is afraid of having this procedure done. And if we really need that, and they will not come for the follow-up in our setup. What guidelines says that is other thing, but the ground reality is our patients are afraid of having these kind of procedures repeatedly. So if you think this virus will not bleed, so then you can put the patient on beta blockers and call him if when necessary. Mark, your comment.
Thanks very much. I usually wait for 4 weeks because of the ulcers which would form after the band ligation. Some centers would call them after 2 weeks, but I would wait for 4 weeks.
This patient has to be kept NPO for 4 to 6 hours because of danger of dislodging of the bands if the food is taken. After that, he can take sips of water and soft diet onwards for next 24 hours. Thank you, Dr. Hassan.
Okay, sir. Now we are going to switch to room number 1, where Professor Yasar is ready with the case.
Okay, Assalamu alaikum. I hope that somebody has presented the case.
Yes, sir.
It is displayed. Dr. Amir, please present the case.
Sorry, this patient is Ahmed Hassan, 71 years old male, presented to us with complaint of on-off mild epigastric pain and weight loss for 3 months. And patient HB is 15.6, platelets are 214, viral markers are negative. And we performed endoscopy. On endoscopy, there was a 5 centimeter hiatus hernia, AFS grade 3, and there was a 1.5 centimeter polyp in the gastric antrum. And on the biopsy, there was a hyperplastic polyp. So we are going for polypectomy and also for H.pylori biopsy.
Thank you very much. It's a very, very interesting case, something that we come across very commonly, that patients suffering from Helicobacter pylori gastritis. I wonder the people who are sitting in the hall, how many of them get themselves tested for Helicobacter pylori. But what I understand that in our country, it will not be wrong to say that 80% normal population is suffering from Helicobacter pylori. 90% people who got gastritis, they are Helicobacter pylori positive. And 97% people who are suffering from gastric ulcer or duodenal ulcer, they are suffering from Helicobacter pylori. Now, eradication of Helicobacter pylori is again a challenge. We are antibiotic consuming country. In the antibiotic consuming country, we must understand that Helicobacter pylori resistance rate, which is in any case high in the other populations as well, but in our country, Helicobacter pylori antibiotic resistance is quite significant, and the kind of medicines which are written in the guidelines and in the books, that generally doesn't work in Pakistan. The classical OAC, omeprazole, amoxicillin, and clarithromycin combination, or amoxicillin, metronidazole combination, which is mentioned in the books. To be honest, it doesn't really work in Pakistan. In our country, nitramidazole resistance is as high as 60%, and clarithromycin resistance is as high as 75%. The various studies which have been done on the antibiotic isolates in the microbial isolates taken from the stomachs in various parts of the country. So the rescue therapy in the other population, that becomes the primary therapy in our country. Now, in our country, it has to be bismuth based. Now it's a separate debate. It's a long debate. Right now, I'm in the stomach, and you can see that in the stomach, uh, there's a uh, there's a clear-cut evidence of gastritis, gala saaf kar lein. There's a clear-cut evidence of chronic gastritis. You can see that this uh, ma- variable pattern. The areas of white, and then the areas of redness, and then over here you can see that um, there's a polyp which is white based, and whenever you come across a polyp in the stomach, one is to look at the size of the polyp, base of the polyp, and then at the surface of the polyp in terms of pit pattern. Now pit pattern becomes very, very important. So but before looking at that, let's go to the duodenum first and see, do we have anything in the duodenum? um, and in the duodenum, again, looking at the upper, at the various walls of the duodenum, to see if we have anything abnormal. We need to look at the surface of the mucosa. We need to look at the vascular pattern. We need to look at the reflections. So multiple things have to be seen in the duodenum, and one is to go all the way down to the distal duodenum in any given case. So over here, I don't see anything abnormal. The valvular conventis are normal. There's no erosions on the valvular conventis. So on the whole, patient is reasonably, patient is good from the duodenal point of view. So coming back to the stomach. In the stomach, one can see that definitely patient does have chronic gastritis. Does this patient have intestinal metaplasia or not? And then going towards the fundus of the stomach, we have to look whether we able to see the underlying blood vessel, not to decide whether this patient does have gastric atrophy or not. So gastric atrophy is not there. LES is incompetent, and according to Hill classification, if I look at that, definitely Hill 3 is there. And uh, on going down, I could see that this hydrocernia. When a person has Hill 3 and hydrocernia, we have to see if it's Hill 2 and uh, hydrocernia is less than 2 centimeter. Uh, and patient does require PPI to take care of the heartburn. In those cases, to reduce the requirement of the PPI or to downstage the reflux course, we can consider doing an anti-reflux mucosal ablation or anti-reflux mucosectomy, and which works reasonably well if the person's got a small hydrocernia or person has got Hill up to 2. Why am I bringing up the discussion of ALMA or anti-reflux mucosectomy? For the simple reason that this patient has chronic gastritis and patient has got reflux. Now, this polyp is in all likelihood because of the PPI. PPI polyps is so common. Generally, these PPI polyps are in the fundus of the stomach. And with the multiple polyps in the stomach, at times there are neuroendocrine tumors as well in this scenario. But uh, if the histopathology has been done, it's a hyperplastic polyps. So hyperplastic polyps are generally because of the PPI. Now, how can we avoid giving PPI in a patient like this? Obviously, we need to have a comprehensive evaluation of this patient. In addition to Helicobacter pylori related biopsy, uh, or as per the Sydney classification biopsy, we need to take at least 6 to 8 samples. Now, 4 samples, one on the anterior side, one on the posterior side, one along the incisura, one along the greater curve, and then in the body here, one here, one here, one here, and one here. And then in the fundus of the stomach to pick up the uh, gastric atrophy at this particular point. So these are different areas for where I shall like to do the biopsy. At the same time, I shall like to take a survey of the stomach with the help of personally I'm using Olympus, so I'm more comfortable with the NBI. But right now I'm using Luxuria, the latest system of Fuji, And let me tell you, the 3D system is very good. One can enhance the image. One can look at the vascular pattern. One can look at the mucosal pattern. Now, looking at the mucosal pattern closely, generally, this is the classical pit pattern that we get in the stomach. But over here, the pit pattern is little elongated. So usually we do this examination with the help of cap or under the water. But if you look at this pit pattern, little crisscross pattern is there. The base is white, but there's nothing significant. If this pit pattern is elongated a little more and it becomes bizarre, uh, there's always a possibility of an early malignancy in these kind of lesions. But this appears to be a classical hypoplastic polyp. We can always have a discussion that does this patient really need polypectomy? To be honest, if it's a classical PPI polyp, I shall not even bother about doing the polypectomy if it's a single one. If they're multiple one, if they are bleeding one, if a person has presented or is presenting with recurrent GI bleed, yes, in those cases, I shall like to do polypectomy, and I shall like to take away as many as possible. Now, with a change of pattern, this is what yeah, LCI, and with LCI you can see that we can see the polyp in more detail in terms of the blood vessels and again the pit pattern. So these are different modes which are there in the new Fiji Lucturi system, which helps in making a better evaluation of the polyp. So for the younger audience sitting there, you have to know your system and the facilities which are there in the system. Based on this system, and you see BLI even further augments the pit pattern. In addition to the Vostel, now you can see that it is much better in terms of characterization of the pit patterns. One can see that again, there's no crisscross. These are just elongated pits on the polyp. So can we switch off and go back to the standard light? Yeah. Now over here, the difference here is that yes, patient does have chronic gastritis. So first of all, let's take the biopsies, and then I shall do the polypectomy. Why I'm taking biopsies first? Because then while taking out the polyp, I have to remove the endoscope, and again I'll be going back in. So biopsies. How many biopsies? As per the SETD protocol, we have to take at least 4 biopsies from the antrum, 4 from the body, and 2 from the fundus region, so that we may be able to have a better evaluation in terms of not just Helicobacter pylori, but the complication of Helicobacter pylori in terms of chronic gastritis and salmonella and rest, or maybe possibility of gastric atrophy. Does this patient have any pre-malignant area? The answer is no. I have done the surveillance and I have not found anything abnormal in that account. Open, please. Now, will you like to do a spike biopsy forceps or a standard biopsy forceps? I think in this scenario, a standard biopsy forceps is good. Open, please. Close.
Sir, are there any findings on endoscopy which suggest low likelihood of H. pylori infection?
You see, with this picture, it should be presumed that this is Helicobacter pylori unless proven otherwise. So this is a classical picture of Helicobacter pylori. Open, please. This is not a classical picture of type 1, type A. Close, please. This is not a classical picture of autoimmune gastritis. Autoimmune gastritis is typically normal in the distal and more in the proximal stomach. So this is not a picture of autoimmune gastritis. This is a classical picture of type B gastritis. So we have got type A, type B, and then as per etiology, open please. As per etiology, non-specific gastritis. Close, please. So, what are the views of the hall in terms of Helicobacter pylori eradication? Open. Close. Any comment from the hall in terms of Helicobacter pylori eradication? Generally, how many of us will go for eradication. Now, another very important thing in terms of when we're talking about Helicobacter pylori eradication, uh, that that thing is Helicobacter pylori relapse. Is it relapse or it is recrudescence? Just a reactivation of the previous infection. Open, please. So, close. So it is always difficult. Reinfection versus recrudescence of the previous infection. New one, please. Second. So reinfection versus recrudescence of the infection. When you have 80% of your normal population suffering Helicobacter pylori, you have contaminated water, you have contaminated food. Is it really worth eradicating Helicobacter pylori eradication in each and every patient? It is more of a philosophical debate. Personally, I tend not to give Helicobacter pylori eradication in each and every patient. I'm very selective in giving Helicobacter pylori eradication, and I give Helicobacter pylori eradication if a person's got duodenal ulcer, gastric ulcer, maltoma, maybe early gastric cancer. Open, please. Early gastric cancer, close. Only in that scenario, I shall like to give Helicobacter pylori eradication.
Dr. Vyas, this is Wasim here. So patients who have reflux, isn't it like a H.pylori is like kind of a protective mechanism? So we try not to treat patients who have chronic reflux.
That's a very important comment that we don't really know. There's no absolute consensus on that, whether the Helicobacter pylori is a protective factor or it is just one of the coexisting factors. Helicobacter pylori eradication, does it worsen the reflux course? Yes, there are suggestions, but there's no consensus on that. Open, please. But definitely, those people who are to be on Helicobacter pylori for a long period of time, they should have, of the people who have to have NSAIDs for a long period of time, or maybe aspirin. In these cases, in these cases, we should be eradicating Helicobacter pylori. Next one.
The other question is, the biopsies, are you putting them in one jar or you separating
No,
them out?
we are doing it in separate jars.
So, sir, regarding Helicobacter pylori eradication, so many of the patients, they have the knowledge of having gastric cancer associated with H. pylori infection, and they ask you this particular question: will I get the cancer if I don't treat it?
उधर जाके चुप कोई एनेस्थीसिया वाला बंदा है
Yes.
एनेस्थीसिया वाले आप
जी सर, ये
अच्छा चलो इसका यार देखो क्या क्यों मसला. Actually, the patient is desaturating, maybe because of the excess sedation that the person received. Generally, we don't get to get this kind of issue in these patients. Open, please. Close. Okay, now it's good. Thank you. Now saturation is back to 90s. Now, coming back to the polypectomy, we can debate that do we need to lift the polyp, or we just have to cut the polyp. In hypoplastic polyp, we just have to cut the polyp. It's a small one. Open, please.
Professor
It's a small.
Vyas,
Yes.
what is your policy with regards to testing for H. pylori? We know that it's positive in large number of population, and generally only symptomatic patients are tested with a view that if they come up positive with report, you need to treat it, or otherwise. What is your policy?
You see, if my endoscope is inside, then maybe I shall be doing the snare, please, 1 centimeter. In that case, I shall be taking the biopsy from the stomach, but otherwise, non-invasive C13 urea blood test. I think I'm very happy with that. The results are very good. Stool antigen, easy to do, but the results are very erratic. One has to send the sample in a stored fashion, so lots of issues. Now, it's a small polyp. We can do it in a cold fashion, we can do it in a hot fashion. Generally, with this scenario, I shall look at the turgidity of the tissue. If it's a hard one, I shall switch on the rectal surgical current. Otherwise, I shall do it a cold one. With a polyp size less than 10 millimeter, I'm not too bothered about bleeding. If the bleeding has to occur, it is going to occur at that time. I can always manage that with the help of quick grasper or with the tip of the snare. Otherwise, generally with a cold snare, delayed bleeding is not an issue, and with a cold snare, people tend to bleed just for the short period of time, and that's it. It's a magnified view. In the magnified view, people get scared with the sight of blood. The more you do it, the more comfortable you feel. Open, please. So going to the base, bringing it to the right position, close, please. Now lifting it. Now the coordination between me and the my assistant becomes very important. Does he think that the rigidity is good enough? Does it? Do we need to apply the electrosurgical current? So the assistant and his field becomes very important. Otherwise, I can do it myself as well. Okay, there we go. Cut. Now, are we worried about this bleed? We just have to wait for some period of time. And generally, this bleeding stops automatically. Electrosurgical current, yes, we can apply that. But in a soft polyp like this, generally, I'm not too bothered about generating the electric current in this patient. So bleeding has stopped, so I'm not worried. With a small polyp like this, do we really need to look at the base? The answer is no. Any question? Any difference of opinion?
So for how long will you be waiting for this bleeding to stop completely?
30 seconds or 1 minute at the most. While I'm trying to take out the polyp, you can see that bleeding is already stopped. Open, please. Close. Open. Now catching the polyp is again close. So while catching the polyp, what I'll do is that I'll bring it close to the biopsy the biopsy channel, and that shall maintain the suction so that the polyp may not fall off. Ideally, I shall like to have grasping forceps, but unfortunately in the unit we don't have grasping forceps, so we're using just the biopsy forceps. Okay, you can see that polyp is out. It's a small polyp, roughly about 4-5 millimeter, nothing big. And you can see that beneath that the stalk is has been taken out. So we are all good. Any question?
Sir, thank you very much for nice demonstration of cold snaring.
This is the next case on station 2. A 60-year-old lady presented with right hypochondrium, pain plus anemia. Her fecal occult blood test was positive. Colonoscopy was performed, which showed large pedunculated polyp just on crossing the hepatic flexure. So our plan is to perform a colonoscopy and polypectomy of this polyp.
Thanks very much. We are having a little bit of hypoxia situation here. And, while doing endoscopy, although we focus on our work, but I think situational awareness is an equal part of our job. Thank you. So why was the colonoscopy done for this patient in the first instance? Sorry, we missed the presentation.
She had anemia and her fecal occult blood test was positive.
Oh, excellent. Thank you. And have we explored the upper GI tract and We have ruled out celiac and everything else.
No, we just performed a colonoscopy and we
Sure.
found that polyp, and we thought that this is the culprit lesion.
No,
Excellent.
Hassan, my question, as Dr. Hamad said, if the fecal occult blood is positive, did she have upper G endoscopy, or you straight away went for a colonoscopy? And what was the reason to going straight away for colonoscopy in her case?
Dr. Habib, can you please explain?
Yes, sir. EGD was performed 6 months ago. That was absolutely normal.
Okay.
So,
So upper GI, no, the upper GI was done, and the cause of bleeding was excluded. And one was
इसको भी
was
bend
the colonoscopy done in
नीचे
this
वाली टांग
patient?
भी bend कर दें, दोनों इकट्ठी bend कर
about 2 weeks ago.
इकट्ठी
Few
bend
weeks
कर
ago. And
वो
what
एक
did
ऊपर
we
नीचे
find in
करके
that?
There was a polyp.
बस ठीक बस ठीक बस ठीक
Okay.
You
Polyp at
I've done. May I start करूँ? Thank you. Okay, start the colonoscopy. I heard that there is a parallel case that you wanted to see because you do not want to see a boring diagnostic colonoscopy. If you want to, we are more than happy, of course. So the first, obviously, when the patient comes to the room, we do the digital rectal examination, and we should not miss doing a digital rectal examination. It has its own value, although we are going to see with the camera and we are going to see in the retroflexion, but as of yet, at least in the UK, we haven't taken away the digital rectal examination out of the picture. It helps us diagnose a lot of perianal lesions, even on the outside sometimes. Okay, so thank you. Ideally, ये हटा दें सारी चीजें, please. Thank you. Right, so we are in the rectum. It's a bit of wet prep. We'll just come out a little. She's got some hemorrhoid. We'll look at them later. So I'll see if I can suction some of it. The solid bits are not so solid. They are semi-solid. Probably we can suction those. So looking at the rectum once again. So anything that we want to suction, we just bring it at 5 o'clock, 6 o'clock position. Makes it easy for us to do any therapy usually. Okay, so
Can you explain us some tricks of doing this boring colonoscopy? As you said, this is not boring.
Well,
this is a trick.
So
There are so many people who are very fond of learning these tricks.
Thank
doing
you.
a good colonoscopy.
Well, a good colonoscopy starts from a good bowel preparation, even before the patient comes in. That's the first thing. And secondly, the indication has to be secure. This patient has got a very genuine indication, of course. And then our best friends are 3. I usually think about 3 best friends. One is gravity. One is the suction button, and the third is the patience. So there's no pushing in any endoscopy actually, but particularly in colonoscopy there isn't. And then practicing the tip control is the most important. So torque steering, torque with your one hand and steering with the other.
Torque in clockwise or anti-clockwise?
Well,
What is
depending
your practice?
depending upon how you. The common practice in old school, without the scope guide, is to use the clockwise torque in the left colon, and sometimes anti-clockwise if if you have a reverse alpha loop.
This is very important because when you just pushing, you may end up with having loop.
So do we have? So then now using the gravity as my best. While we, as soon as we enter the sigmoid, if we put a lot of water, the weight of the water will kind of straighten the sigma of the sigmoid, and then that will help us. Thankfully, these patients are nicely sedated with the help of our, very, very helpful anesthetist. So we really do not worry too much about the discomfort to the patient. But at the same time, we have to remember that if the patient is relatively awake, we get the feedback signal that they might be, having some pain or a big loop. The perforation during colonoscopy, especially diagnostic, does not happen with the tip of the scope. It happens with the part of the scope that we are not watching, we are not seeing. So a relatively awake patient, if you are putting too much stretch on the mucosa with a big loop, They would tell us I'm feeling pain, but a deeply sedated patient or anesthetized patient wouldn't, and we might just perforate them silently. So going further in, working through the bubble, not only I'm doing a little bit of advancing the scope, but also suctioning and pulling backwards, trying to straighten the scope. So my scope is pretty straight. Here, probably we should be at this splenic flexure, but it's not so easy to identify the landmarks in this rather mobile colon.
What
Okay.
number of ball preparation in this particular case?
Well, so there is one famous Boston scale of bowel preparation. You give points out of 3 for all 3 parts of the Do we take pictures? Does it take pictures? Okay. So you can see the polyp here. I'm not entirely sure about the location as of yet, and the stalk looks really chunky here. Okay, so again, might be taking help from the gravity. I might change the position of this patient in a minute. Let's see. Let's just complete the colonoscopy, and then we'll move on from here. So in the meanwhile, if the house would like to talk about the types of the polyp, the classification, the the Paris, maybe the JNAT, or there are other classification systems like NICE, for example, and then pit patterns, the Kudo, and also the SMSA scoring, etc. While I'm trying to negotiate with this area. Okay, so I'm just gonna go through with a push a little bit because we've found where the money is. We'll move on from here.
So,
and
Doctor,
try and figure out. Yeah.
Dr. Ahmad, so once we find this kind of big polyp, and there is a stalk, does it really matter that what kind of bit pattern the patient has?
Not really. We still would want to see if if this polyp is pedunculated or sessile. How big is the pedicle? Because we really need to deal with the complication that could happen. This is a really large polyp, and I'm trying to understand where we're going to go from here. And where? Sorry.
So would you
I
like
might
to
use the
go
word
for
pedunculated.
CT scan in this kind of patient where you find large
I would
polyp?
probably, I would have, I was about to ask this question after seeing this polyp. Did we take any biopsies last time? Do we know if there is any, already high-grade dysplasia? Because we didn't remove the polyp in the first index colonoscopy very sensibly. Were any biopsies taken at least for this kind of? Okay, yeah.
So regarding the biopsies, if we do not find any risk of tumor like loss of vascularity or loss of architecture, will the biopsies be of any help in deciding whether we need to take this polyp out or not?
Okay, so very good question, and there are 2 parts to this question in my opinion. One is that which lesion should we biopsy? Because there are certain lesions we would rather not biopsy because that will cause fibrosis and later endoscopic removal will be quite challenging. Whereas in this type of polyp, of course, we can biopsy very.
Mark, with a big polyp like this, will you even bother taking a biopsy, or you'll like to straight go for the polypectomy?
I'm thinking about maybe even bailing out. I'm seeing some features which might worry me. Can we supine? I'm curious whether this is already translated, whether this is already deep invasion here. So I really want to examine the polyp better, but let's see if I can go further. And that's why the question of CT scan was, I think, was asked earlier on. Yep, thank you. So the patient is in supine now. The bowel preparation is quite all right. Okay. We're in the polyp vicinity again. Yeah. Okay, so we are in the cecum now. Let's clean and just rule out any other potential synchronous lesion, another polyp which might need dealing with. Infocolia is a bubble break है कोई हमारे पास जो like a simaticon तरह की कोई चीज that would be very good actually if we can remove these bubbles.
So, Mad, are you going to do it underwater or are you going to do it under air?
I don't think I need to do it underwater. I want to make sure first if I want to do it today, to be honest. Let's just reach the polyp in a minute and then figure out, discuss about the surface features and the real thing, the assessment of the polyp, and then decide how we're going to remove it. But I don't think I need to do it under the underwater. I think we'll just inject the stock, and then do a hot hot snare polypectomy. Now the question for some people would like to prophylactically put a clip on in such polyps. I don't. I put it afterwards, but I would appreciate what other people, if you let me know what other people's do.
So it really depends on the size of the stalk. If the size of the stalk is big, there's no point in putting in a clip on one side. But if the size of the stalk is thin, yes, there is a point. But then in a thin stalk, in any case, there's not much risk of bleeding. The risk of bleeding is always with a thick stalk.
Yeah. So my reasons to not put a prophylactic clip is when I'm putting energy through my snare, that might focus on the clip, that might like the metal more than the mucosa, and burn a lot deep and cause a perforation later. And that's why I'm happy to see maybe some bleeding. And then a lot of people are familiar with the loop, and many people still use them. I personally absolutely hate it and do not use it. Again, I would appreciate the other colleagues' practice.
So, in a polyp like this, where we are dealing with polyp on, especially in the right side of the colon, I'm very much worried about bleeding and perforation both. So, what I would be doing is to inject at the base to clear the demarcation between the polyp and the polyp stalk, number one.
Yeah.
Using some of the adrenaline, I will be placing maybe a couple of prophylactic clips, because if this polyp bleeds, this large polyp would definitely be having a thick stalk. So I think it's advisable and advisable to do the prophylactic clipping instead of having a lot of bleeding, and then we will managing the bleeding afterward. Using the electrocurrent in the presence of prophylactic clips is usually not an issue with
I'm gonna cut you
with
off.
large stalk,
I'm sorry.
like in
Is
this
Dr.
patient.
Rias? Okay, so what does the house think about this area? So on the right side at 4 o'clock, 5 o'clock, we have an adenomatous area.
Yeah.
What about this area in the, at 6 o'clock or in the focus now? Are there, are you able to see this, the area which I want to demonstrate to you?
I think with this picture, we can straight away say that this is the insight to see it definitely.
Thank you, sir. Thank you. So should we inject the stock? Should we do a lift test or no?
Definitely, yes.
Yes. So you think I should lift and remove it?
Yeah, if it's removable, why not? It all depends on the CT scan. If they have,
I think this is quite a regular area. But I'm not comfortable in removing this polyp endoscopically. I want to biopsy it from here. I want to do a CT, and I really want to make sure that it is safe to do so. I
if
think
the
this is
CT has been done and there are no lymph nodes and there's
Can we take a
no
picture of
invasion
this
in the
area?
wall, I shall say that go ahead. If there
Yeah.
are lymph nodes in the vicinity,
Yeah.
or there's wall invasion, definitely no.
So, Professor, I'm so glad that you are here. I'd really appreciate if you can also teach us what are the features I'm looking at which make me stop taking my snare out.
You see, if you look at the surface, you can see that the surface is ulcerated and it's bizarre. The classical kind of pit pattern that's lacking. On the proximal side, you demonstrated the pit pattern very nicely. That was adenomatous. They were elongated pits which were crisscrossing each other, and there was nothing sinister. But the area that you showed on the cegal side, definitely it was ulcerated and the surface was bizarre.
So please do also comment on using the NBI. Most of the classifications, they have the NBI on the basis. And in our setup, I've heard some places where you can't even do the narrowband imaging. It's okay. Okay.
I think in all the new processes that irrespective whether we're using Olympus or Fiji or the other one, Pentax, they all have image enhancement. And even if the image enhancement is not there,
Yeah.
putting the water there and examining the polyp under the water again gives us a very good idea about
Absolutely.
about the nature of the disease.
Yeah. And now other another comment about using the air versus CO2. I do all my procedures, even upper and lower, with CO2 nowadays. For some
Yeah,
reason
I
or the
entirely
other.
agree with you that in current era, doing it under air is making patient more comfortable. But for many, many years, I've also stopped using air. I do all my procedures under CO2.
Absolutely. Even the diagnostic simple procedures, because you do not know which one is going to turn out to be a therapeutic. So we start with CO2 straight away. Okay. So are you happy for me to take biopsies only today?
No, we haven't seen the stock yet.
Yeah.
But how about the CT scan? What are the results of CT scan? Or CT scan has not been done.
Okay. So can somebody comment on the size? Would somebody like to guesstimate the size of this polyp?
It's almost they have 1/3 of the lumen.
Yeah.
So if you look at the stock, if we can put in a cap and look at the base, I think it's a thick stock lesion.
Yeah. So for me, this is more than 5 or even 6 centimeter. In my opinion, I'm going to change the position again to try and get the help from gravity again. I might change her to the right, but let's move her to the left first because that's easier. And let's see if that drops the polyp downwards. And those people who are ESD enthusiasts, obviously, they the traction is one of the key elements of that, and they would really like to see.
Dr. Ahmad, are you able to retroflex and see maybe you can?
Right. I think I would struggle. I'll give it a go, because looking at the situation, let's just put some air. Let me see if I can. जी सर वो कर देते हैं. Let's see if we can retroflex.
So for retroflexion, I think it would be easier if you go in the cecum and then you can pull the scope back.
I was hoping if I could do it here, even in cecum. I'm not sure because the anatomy was not very much favorable. Let's just try here again. Yeah. So I worry a lot about perforating the cecum. So I try not to do it. I usually go in a different plane to look for polyps in the areas, but it would be very helpful if I could do it. So do you want to give it a go? Do a retroflexion in the right foot?
I'm not interested in retroflexion. Just to show me the
Yeah.
stock again.
Yeah.
You have
Let's
good
just
position.
and one of the colleagues, Dr. Akif, he has suggested why don't we throw some water here and see if this floats. With the weight of this, I'm not sure if it would, but let's put some water. So again, another question which I've never found an answer to is about tattooing of such lesions. Has anybody ever seen availability of tattoo here in our country?
You see, tattooing, you can always get the dye from the laboratory people. That's not an issue. Um, Generally, we get it from our laboratory. Previously, we used to get it from LGH, and I have it in my endoscopy room, and I've got it from the pathology department.
Really helpful, really nice. So you do have access to.
We usually use India ink for
India pink.
Yeah.
tattooing. It's available from the labs, but we don't have any. We don't have any dedicated agent by
So there isn't much, very
endoscope
little,
suppliers in
very little,
Pakistan.
very small. It's twisted. This is the the star.
So, where exactly do you do the Indian staining in this patient?
Sorry,
For the
what's the
surgeons to-
question? So if
Where exactly do you do India staining in this type of polyp?
Yeah, so we, for the polyps, the question is that is this tattoo for a surgeon or is this tattoo for the next endoscopist or even myself? So if it is for myself, one tattoo on the anal side, about 3-5 centimeter on the antimesenteric border. And that's to prevent the migration of this tattoo and cause fibrosis, etc., etc. Whereas if it is for a surgeon, for a laparoscopic surgeon to see the anal extent, then it is 3 tattoos in a triangle, on the anal side, and that.
Why don't you manipulate it with the snare, just to tip of the snare?
To see the. What?
Another trick is you can use the cap.
Well, you can certainly use the cap, of course, but my worry is that I'm not even interested in trying to, because my thoughts are that this area in the center of this large polyp has very well demarcation of deep invasion. So this area, yeah. Okay, so my main focus is to try and take some samples from here, and if it proves to be
Give us the biopsy for
cancer, maybe she would be better off with the right hemi, to be honest. What do you think, Home? So this was biopsied. Oh my God.
This is not hyperplastic.
I'm not sure if I'm not sure if this is hyperplastic. We can
seems to
see.
be,
I can definitely say this is an adenoma with at least low-grade dysplasia, almost certainly high-grade dysplasia, probably carcinoma in situ at least. But I think it's a bit more than that. I think it's more than T1. Biopsy for second. Thank you. Sir, very, very thick area. This is a subpedunculated 1SP polyp.
So surgeons here are interested in operating this case.
Sorry?
Laparoscopically?
Yeah, of course.
If
Lab
biopsy comes to be a malignancy, we can go for the laparoscopy.
lab right hemi is the best treatment. Close. Okay. So I think I had shown the stock earlier on. Let's just have a look at it again. That's very, very thick. That's very thick. So that's the stock. That's the stock. Okay. And you can see the pulsation of the artery there as well. So would you like to do
snare दिखाओ जरा बड़ा snare
I'm not comfortable dealing with it without proving as much as possible, without a CT, without. Yeah. Okay, so that's the stock, and I was talking about the SMSA score. Please feel free to calculate. Yes, we've used it, sir. NBI. We started with NBI actually. That helped us a lot. Trying to identify that particular area.
27 है ना? No, this is not, but this is malignant. With carcinoma and cyto.
So this area, sir.
This area.
Yeah. This,
Would you like to
no, sir.
say
This is the central depression.
Yeah.
Indication of malignant transformation of this. It used to be. ये जो sir गंजा हुआ हुआ है. This is malignancy.
Ulceration hai aur
Yes.
loss of
Exactly.
appearance.
Professor Giyas has used a word bizarre, which is I think the best way to describe the pit pattern there, a vascular pattern and pit pattern both. Okay. So biopsy, CT, open please. So now biopsying such polyps is also another challenge because sometimes you get the suboptimal yield. You might have to go back in again because my suspicion is very strong of this malignant transformation. And then biopsying a particular area is also important. Which area do you want to biopsy?
Dr.
And then
exactly.
at the
This is
flexures,
very
it's
important
notorious that
for someone
your
to
snare,
take
your forceps
biopsies
will
from
come in a
right area.
at an
Otherwise,
angle
we
which is
will
the
be
least
having
help. We'll try and not change her position now. We'll try and take some biopsies. How many biopsies would somebody take here? Close.
So at least 6 to 8 biopsies, and this thing is very important that we need to take the biopsy from the right area. Otherwise, patient might not be having the true picture of biopsy results.
Dilatation. Okay.
You are going to take biopsies and finish this case?
I think so.
Okay, so can we shift to other room?
Yes, please.
Okay, thank you. So Dr. Amir, please present the case.
Yes, sir. Sir, this is the patient Muhammad Tanveer.
Sir, you are on. We can hear you. Dr. Akif?
Yes. Can you hear me?
Yes, sir. Loud and clear.
Sir, this is the patient Muhammad Tanveer Babar, 56 years male, presented with complaint of dysphagia for 9 months. And on barium, there was a typical bird beak appearance. And endoscopy showed dilated tortuous aperistaltic esophagus. And on high resolution manometry, it's type 2 Achalasia cardia with ERCP 39 with 100% failed peristalsis and pan esophageal pressurization on 100% swallows. So we are going for pneumatic dilatation for Achalasia cardia type 2.
So we have just washed the esophagus. You can see that this is Dr. Essen, can you hear us?
Yes. We can hear you.
So you can see this is a dilated esophagus and contain lots of food particles which has been flushed recently and aspirated. And if you see, just do not put any air and just wait on to see is there any peristalsis or there is lumen apposition in that case. So I'm not putting in any air, and we are just waiting to see if there is any peristalsis. So you see, we are standing by, and there is no opposition of the lumen, which may reflect that a meaningful peristalsis is there. So we have documented that there is absence of peristalsis, and as well as the esophagus is markedly dilated. As we go down, you can see this looks like a colon rather than esophagus. There is there is significantly dilatation and thickened fold, Lugi, and as we go down, we note, sorry, that there is puckering of the fold, and as we reaches close to the LES, it is tightly closed. So you need to go close, put some air, gentle pressure, and try to move it. And as you go through the lower esophageal sphincter, you have a sticky feeling. Those who used to do endoscopy regularly know that as you move across the LES, there is no stickiness. But in patients with achalasia, you see, and that is a thing that you feel on your hands, that once you push across a tight LES, you feel that it is not going freely, rather it is sticking along the wall, and then you need to give us a gentle push so that it can go through. So again, हम इसको एक दफा दोबारा demonstrate करते हैं. You come back, and you see that this is the
So these are the signs of advanced achalasia, of chronic achalasia. As already Professor Gyas told, you should be having you should be having very high suspicion, index of suspicion if the patient is presenting with dysphagia and we are not finding any lesion. We should be giving ample time to see for any peristaltic activity, and if there's no mass lesion, no obstructive lesion, you need to take biopsies for eosinophilic esophagitis, and you should consider achalasia and your differential. So this dilated esophagus containing food residue, secretions, these plicated folds, then resistance across the LES, then sudden giveaway. These are the classical features, and these come in advanced cases where you are dealing with the symptoms are persisting for some time.
So another important thing is to look for pseudoachalasia.
Yeah.
So if the patient is elderly or patient has some other constitutional symptom, always look for pseudoachalasia, especially
this is
the cardia.
yes, this is very important that in any patient you have got some resistance across the ears, you need to retroflex and you see whether there is any mass or anything that is obstructing the esophageal outflow. Here we can see that it is and the picture also shows that it is tightly clasped around the scope, which is also a feature in achalasia cardia. You can see it is tightly clasped around the scope. So once we have seen it, we have gone beyond. We have seen the stomach and esophagus. I think the next step is that we need to make a decision for this patient. I think with type 2 achalasia cardia, we have got all three options for this patient. That one is we can do pneumatic balloon dilatation, 2 we can do POEM, or we can do Heller's myotomy. So all three for type 1 and 2, we are good with all three options, and all three options are recommended. But for type 3, the POEM is preferred. For this patient, I think we have lined him up for pneumatic balloon dilatation. So we are going to do balloon dilatation for this patient.
Are you using CO2 or air in this patient?
No, we don't have CO2 here, so we are using air. That is a handicap, especially when we want to see the post dilatation area. We really needed CO2, but we don't.
So
have
ideally, CO2 should be used because post dilatation there may be a significant tear, and it's always safe to use CO2.
And the next thing is the wire you are using. Some people use this ERCP wire for this. I usually use this steel wire. It has got better grip and it is easy to push on it. And so we'll place the wire. कैप तेरा बिल्कुल नया है, खोल लो फिर या चेंज कर लो.
So with availability of POEM, we are doing more and more cases of POEM in all types, but the evidence suggests that you can go with POEM or pneumatic dilatation or Heller's, especially in type 1 and also in type 2. But in type 3, clearly evidence suggests POEM or Heller is better than pneumatic dilatation.
So we see we have placed the wire in the stomach, we are deflating it, and as I am giving small pushes in, sister is pulling the scope out so that the wire remains deep in the stomach.
Is your patient in the left lateral position, supine, or prone position? What is the position of the patient for this procedure?
Patient is in lateral, left lateral. निकालते जाएं. हाँ, निकालते जाएं. क्या बात? निकालते जाएं. Good. पकड़ लें.
So in this case, we are proceeding with a 35 millimeter balloon, but you can start with the 3 millimeter balloon, 30 millimeter balloon. There's some evidence that there are some predictors of good response, like if the patient is female, age is more than 45, you can use 30 millimeter balloon. But if the patient is young and male, you may be opting with a 35 millimeter balloon because the muscle may be thick in such cases.
So here we have got Rigiflex balloon. This is available in 3, 3.5 and 4 centimeter. Here we have got 3.5 available with us. So what is the usual practice of the audience with reference to the first time dilatation, either
majority of you uses start with 35 or 30 to begin with. I usually used to go with 30, especially with older patients. However, in younger patients, one may start with a bigger balloon. So, Ghyas, what is your practice?
So in male patients, since we see in POEM patient that they have thicker muscularis and that is very hard to be broken down. So 35 is fine with the male patient with thick muscularis. But if we are dealing with a female patient, usually I start with 30.
बेटा आपने ये वायर को नहीं छोड़ना तो वायर
And elderly patient who are frail, we also start with a 30 if we have to go for the balloon
कुछ
dilatation.
लगाओ इसको ऊपर जेल शेल ताकि थोड़ा वो इजीली मूव करे ठहर बैठा है आराम से वायर ना खींच लेना पीछे से चलो जेल लगाओ
Can we have this fluoro image as well?
हाँ so so we are doing it under fluoroscope. People used to we can do it with the
endoscopic
scope
control.
Alongside the balloon and then position. But I think fluoro guided is better in terms that you've got better. So patient को थोड़ा सा suction करें, sedate करें patient. हाँ.
So how do you know that our balloon is right across the LES on fluoroscope?
Yes, it has got markers on it. As we go in, there are two markers on the periphery and there are double markers in the center. So once you place the balloon, you see the diaphragm on the fluoroscopic image. You tend to place the two close marks at that site. And once they are placed, you give a little bit of air to get the face so that you get an idea that your balloon is placed in the middle, half up and half below the stricture, so that adequate dilatation can be done. So as we go in, cameraman, can you show this this bit that balloon have got? Okay. So we'll show it on fluoroscopy. आप पीछे से इसको टाइट रखिएगा, टाइट रखिएगा, वायर खींच के रखें. CM please. दिखाओ जी CM पे किधर.
Fluoro view.
Fluoro
Cameraman to please show the fluoro view.
दूसरे पास, दूसरी तरफ. हाँ ये.
Now we are beginning to see some.
पेशेंट को ना ये नोज से सक्शन करें, नोज के अंदर सारा इसका वो फ्लैम सक्शन कर लें. हाँ दिखाओ आप. हाँ आगे चले गए. थोड़ा सा ऊपर दिखाओ. ऊपर है ये. दिस इज. So here we can see the double mark. Okay, you can, yes, the audience can see that there is a double mark in the center of the balloon that you need to place at the level of the diaphragm.
Yes, we can see that.
And one mark is above and one mark is below. So half the balloon is in the stomach, half in the esophagus, and the double mark is at the LES site. So once we think that we are at the appropriate site, we'll give small amount of air so that a small waist of the balloon is formed. Beta thodi si air do.
So I welcome the Vice Chancellor King Edward Medical University, Professor Mahmood Ayaz साहब.
थोड़ा सा वापस करें मुझे लगता है. दिखाओ.
So sometimes we find it difficult to exactly position the two marks on LES, and in that particular scenario, I think it's always better to either make the patient prone or supine, because in left lateral position, sometimes it's very difficult to exactly place the two marks on the diaphragm or across the LES. Professor Akif, can you hear us?
Positioning him in the supine, in the view that he is an obese patient, and with the lesser penetration, we are not being able to see the balloon. So now the position has been changed, and आप देखो बेटा फ्लोरो, थोड़ा सा position करो patient को, बेटा खींचो थोड़ा सा, चलो. अब आप करो उसको, and we'll see. Adjust करें. हाँ, adjust करें. हाँ चलो दिखाएं. थोड़ा सा मुझे लगता है you need to adjust a bit. पुल करें थोड़ा सा. आप दिखाएं. हाँ आप देखें. थोड़ा सा ऊपर से दिखाना. ना. हाँ आप
कुछ वेस्ट बनती नजर आ रही है आपको? नहीं पता चल रहा? ये यस थोड़ी एयर पूल अब डालें थोड़ी सी और डालें. हाँ,
Now you can see well placed balloon is well placed.
हाँ, ठीक है.
The two markers are on the
इधर
diaphragm.
आ जाओ आप. हाँ, आप एक्सप्लेन कर लें. ठीक है, ये आप.
So can we reduce the magnification of this fluoro image?
Can you zoom out? Can you decrease the magnification?
Now, for the benefit of the younger audience, we must remember that LES can be below the diaphragm as well, and most of the time it's below the diaphragm.
Yeah.
So 1-2 centimeter beyond the diaphragm, that's the place where we need to place a marker.
दिखाओ. Can we see it now? थोड़ी बेटा सेक्शन करके रखें. नहीं बेटा और बड़ा कर दिया. छोटा करो इमेज. छोटा करो. चलो आप देखें कुछ नजर आ रहा है आपको वेस्ट. हाँ. So we have got some idea, but not.
So once the balloon has been inflated, it's always a good idea to slightly keep up stretch on the balloon. The person who is holding the balloon on the mouth end, he has to keep a gentle traction on the balloon. It should not slip down into the stomach.
So in a situation like this, where we do not have the optimal fluoro image, one can place the parallel scope and can have an idea where we are basically.
We can see the upper and lower end now, and I think it is good to go.
Yeah.
Yes. So you can see the upper end of the balloon and the lower end, and there is I agree that it is not that optimum, but we can see that almost
I think that cameraman should zoom out a bit so that
half
we can see
half
the
of the
fluoro
balloon
image
is
clearly.
up and half is down.
Can we have the fluoro image?
Cameraman should zoom out a bit.
Yeah.
नहीं zoom in नहीं करना, zoom out करना है.
थोड़ा सा इमेज को छोटा करो. हाँ.
इससे छोटा नहीं होता.
हाँ,
कर लिया.
नहीं,
चलो बेटा देखो
थोड़ा और छोटा करें. हाँ. Cameraman.
हाँ.
हाँ जी.
हाँ ये.
Now it's better.
Yes. ठीक है.
नहीं आगे करें थोड़ा. More part of the balloon is proximal. It is yeah. थोड़ा आगे करें.
चलो जी. नहीं अब ठीक है.
ज्यादा balloon ऊपर है.
अच्छा.
ना.
चलो अब fully inflated को तो करना मुश्किल है. थोड़ा सा जो deflate
करके. जो junction at
it's
just beyond that diaphragmatic
थोड़ा सा deflate
impression.
करो.
So you should
मुझे लगता है कि वो
push in a bit.
Waste खत्म नहीं हो गई.
Yeah.
So we are already done.
Sir, when I do pneumatic dilatation on this fluoro system, I usually place a marker at the level of gastroesophageal junction, external marker, and it helps me a lot.
Generally, the stomach and E junction is a mobile structure, and it can be anywhere in relevance to the dome of the diaphragm. It can be distal, 4 to 5 centimeter. It can be just distal to the diaphragm. And the more you push, the greater the chances that you're pushing the E junction and the stomach distally into the pectoral cavity and into the abdominal cavity.
क्या करने लगा? देख के क्या कर रहा है? So the pressure, the reason that it is the pressure is not building, that device is probably leaking from the angle. So देखें उसको change करके देख लें. अब ठीक है वो निकाल दो, attachment निकाल दो.
So we can detach the three-way connector at time that is faulty.
हाँ ठीक है.
But I think the more important is the loss of effacement, the loss of waste.
कितना की है? Pressure कितना हो गया?
Rather than the time. You can see there is no waste on the balloon.
Shaukat, there's no consensus on loss of waste only. There are people who like to maintain the pressure for at least 60 seconds. There are people who like to maintain the pressure for 120 seconds.
Yeah.
And then there have been studies where there's been the inflation of the balloon for 30 seconds as well.
Yeah.
But consensus is that at least for 60 seconds, one must keep the balloon inflated. It's not just the effacement of the waste. It has to be more than that.
Okay. Yes, I agree that once the waste is obliterated, you have to keep it inflated for some time, and the time is variable literature. there is a study that have been published through the Sheikh Zayed Center that if you keep it stretched for 6 seconds at 6 psi and the waist is obliterated, this is good enough. So I agree that different centers have different time period that they use, and here we are already fully stretched, and for the last time देख रहे हैं कितना हो गया?
15 seconds.
15 seconds. So we'll do it for 30 seconds at least.
Dr. Akif, can you show the fluoro image?
Fluoro दिखा बेटा.
Yes. Keep it here.
You can see the balloon. You can see the fully inflated balloon margins and the air inside it. And there is no narrowed area, so probably it has been stretched adequately.
Can cameraman zoom out a bit?
So, what are the pressure settings on manometry?
Yeah. So it is on manometry?
I mean, inflation device.
Oh, so inflation device, we have maintained it to
PSI,
to
20 PSI.
20 PSI.
Okay. So it's not just the loss of waste. We have to maintain the pressure at certain PSI, which the company has recommended, so that we can break the fiber. Because at LES, the muscle fiber, they are really very thick, and if we do the balloon dilatation inadequately, patient is not going to have benefit of this balloon dilatation. Although there is the risk of perforation, but that risk of perforation has to be equated against the risk of undergoing the second procedure as well.
Deflate हो गए.
I think higher the pressure, greater are the chances of laceration and perforation. And one must remember that even in the best of the places, with all the due precautions, the best efficacy of pneumatic dilatation is not more than 54%. Is and as many as 46% of patients in the meta-analysis, people tend to have recurrence of dysphagia within 1 year. So that's the reason that in world over, endoscopy form has come. It has replaced the pneumatic dilatation altogether. The only place where pneumatic dilatation still does have a place, that's in type 1 achalasia.
Type 1 achalasia,
and not in type 2 or type 3 achalasia, definitely.
So here we are going down, and just to reassess what has happened. So you can see that we are into the stomach.
No, you can see the scope have passed with ease.
Yeah, scope have passed with ease, and there's no that sticky feeling has not been there now. So if we see it on retroflexion,
So some degree of mucosal tearing is always there with balloon dilatation. So how do you confirm that patient has frank perforation and the patient needs immediate some intervention like placement of stenting, or we need to keep the patient NPO, or we need to call our surgical colleague?
But let me caution the younger audience that unless a laceration is there, you should not be feeling comfortable that you've done the adequate dilatation.
Yeah.
Immediately post dilatation, this laxity of LES is going to be there. So laceration is always there, and don't be afraid by looking at the laceration. Yes, if the patient pulse rate goes up while you've done the dilatation and you've gone in with the endoscope, that means that something is going inside the chest wall. And before the patient leaves the endoscopy room, or before the patient leaves the hospital, it's very important to have a chest X-ray in the patient who has undergone dilatation. Obliteration of the left nose diaphragm or mediastinal whitening or surgical emphysema, straight away that means that patient should be considered for a possible perforation.
There is a tear. So we can see that there is a tear down there, and we are good to go easily into the stomach. So what is the opinion of the audience now?
Okay, don't you think that tears little down at the LES? It's not there at the place where usually the muscle is there?
Yes, sir, you're right. Probably with the compromised fluoro image, it may be a 2-3 centimeter up down issue, but it has eased out at least.
Do you want me to do it again, or should we leave it? And in case of recurrence of symptom, we can do it later on.
It all depends on the balloon that you used. If you have used 3 centimeter, I should say
35.
that 15 days or a month later, we should do it with the 35 millimeter balloon. And if it's a 35 millimeter balloon, then maybe 15 days or 4 weeks later, we should be doing it with 4
Yes, so
4 centimeter balloon.
so we have done with 35 millimeter balloon. So I agree with you that if the symptom recurs, we may do it 2-3 weeks down the line. So the scope has eased out, but there is no significant tear. Yes, and one other sign is that you've got usually a blood stain on the balloon as well. Yeah. That was not there as well. Yeah. But the sphincter has eased out at least significantly. So I think we will do it with a bigger balloon if the symptom recurs with 2 to 3 weeks later.
So for the younger audience, let me caution them that there's always a difference between tear and mucosal laceration. Mucosal laceration, that's something that we want. Tear, that is something that we don't really want.
Yes.
So thank you, Dr. Akif.
Thank you.
So even if
Demonstration.
we have the tear, so even if we have the tear and we are doing it under CO2, we should not be worrying much. We can always place a fully covered stand. We can keep the patient NPO, put the patient on antibiotics, and usually these perforations, they heal by itself.
And we can clip them as well. Okay, but taking the advantage of my age, I shall say that in the current era, in type 1 achalasia, the results of Hellis myotomy and poem are equal. In type 2, slight edge towards the poem. In type 3, a great clear-cut edge towards the poem. Now, the only advantage that you can get with the Hellis myotomy is that one can do an anti-reflux procedure in the same go. There's in the literature, there's 15% incidence of post-poem reflux disease. But to be honest, the patient that we have done in our centers, our statistics are not more than 4%. In our patients, there's a 4%, the data that we have accumulated, 4% cases have shown a significant reflux. Otherwise, either a short time PPI course or maybe as per required PPI is good enough for our patients.
So I agree with Professor, but post-poem, many of the patients, they do have reflux disease, which is asymptomatic, maybe because of some denervation during the poem procedure. And people keep on doing repeat endoscopies to see any stricture, changes of reflux and pH metry. But yes, symptomatic reflux is not much as has been previously thought about poem procedure. And there is no difference in anterior or posterior poem now.
Yeah, I totally agree. At the moment, whatever achalasia patients I get, they're usually almost 99% of the achalasia patients which I get, they're really, primarily coming to me as a surgeon. They're all which have actually failed an attempt or a repeated attempt for dilatation or something else. But first of all, they have to go, and they should go, and they have been going to the gastroenterologist first, and then they, in case if there's a failure of a procedure, or the patient becomes uncomfortable with the procedure, only then we go for a laparoscopic or robotic Hellis myotomy.
Okay, now taking advantage of so much faculty over here, I call Professor Israrullah Tour for his comments and.
Thank you very much, Hassan. It's my pleasant duty to welcome our Vice Chancellor, Professor Mahmood Yas, and all the Galaxy of stars from all the hospitals of prominent hospitals of Lahore. Sir, thank you very much. आप सब लोगों का आना यहाँ पे हमारी इज्जत अफजाई है और हौसला अफजाई है हमारे सारे स्टूडेंट्स की। और इस तरह के मैं अभी बता रहा था कि 12 केसेस हमने इस वर्कशॉप में किए हैं, लाइव केसेस हैं, सारे कॉम्प्लिकेटेड केसेस थे और अपर जीआई, लोअर जीआई और एक ERCP का केस था। इसमें जब हमने शुरू किया था यहाँ पे, ये 3rd कोर्स है हमारा, 3rd वर्कशॉप है जी। अब जब हमने यहाँ पे डिपार्टमेंट में शुरू किया था तो गैस्ट्रोएंटरोलॉजी सर्विसेज को बहुत अच्छी हालत में नहीं थी। साहब की विजन थी, प्रोफेसर महमूद याद साहब की, कि उसको कुछ बेहतर करने की ज़रूरत है। तो उसमें हमने अपना हिस्सा डालते हुए इसको शुरू किया और आज हमारे यूनिट में सिर्फ नॉर्थ मेडिकल वार्ड में तकरीबन 170 टू 175 केसेस हम एक महीने में करते हैं और ये कंसिस्टेंसी है हमारी सर्विसेज की फॉर द लास्ट 3 इयर्स। और इसमें एक दिन का भी तो नहीं आया किसी भी वजह से, ना एडमिनिस्ट्रेटिवली, ना ही कोई इक्विपमेंट वाइज, ना ही मैन पावर। जब हमने शुरू किया तो शायद थोड़ा बहुत मैं करता था, अब हमारे साथ 4 और मुझसे बेहतर करने वाले एंडोस्कोपिस्ट इस यूनिट में काम कर रहे हैं। और ये जो है सर्विसेज सर से रिक्वेस्ट है कि इनकी विजन को एनहेंस करते हुए हमें ज़्यादा स्किलफुल हैंड्स और ज़्यादा बेहतर इक्विपमेंट की जो तलाश है और ख्वाहिश है, उस पे ज़रा सीरियस कंसिडरेशन शो की जाए। हम सब के तकरीबन इस हॉल में सबसे जो मेंटोर हमारे सारे असातिज़ा हैं, लेकिन जो मेजॉरिटी के एक कॉमन उस्ताद हैं प्रोफेसर यासुन नबी तैयब साहब हैं। मैं चाहूँगा कोर्स के बारे में कुछ इज़हार ख्याल करें।
Bismillahirrahmanirrahim. Thank you very much, Strasab. Thanks for the invitation. It's always good to come back to my hospital. I'm a graduate of King Edward Medical College. I did my house job here. I did my residency here. And since 1992, I'm out of this hospital. But every time I come back, it always gives me an immense pleasure. And while we were working, I was getting training in medicine here and subsequently in gastroenterology in my hospital. MAYO was the registrar at South Surgical Ward. I was in East Medical Ward. We had a wonderful time together, and though working in separate institutions, we always maintained contact. He did an excellent job. He excelled in surgery. I did my level best, and I tried to work. I tried to as good as possible in my own domain. So we have worked parallel to each other, and I always felt happy and um, uh, elevated every time I come across Professor Mahmood Ayasab. Currently, he's VC of my alma mater. Wish him all the best. And similarly, I've been working with Israr Sahab ever since I came back to Pakistan from UK. He was in the first batch. He worked with me as a house officer. He worked with me as medical officer, then as senior registrar, and then for a long period of time we worked together as a faculty. I think हम लोगों का जो साथ है for good, if I'm not wrong, 20 years का तो है, 20 plus का. And the same goes for Imran Saab. He was working as senior registrar in Jinnah Hospital. When I approached him कि यार वहाँ पे क्या कर रहे हो तुम, LGH में आओ, and he established a department of endocrinology over there. He was a big asset to LGH. Not only that, he improved the medical education quality in LGH, but at the same time he built up a beautiful diabetes center. We benefited a lot from his expertise and his services in LGH. He then later on went to Saiwal as principal, and now currently he's heading East Medical. He's in East Medical, West Medical ward. Imran Saab, he has been. Imran Saab is in East Medical, and Imran Saab was my house officer when I was medical officer in East Medical back in 88, 89 or 1990. 91. So again, we have a long association. All the people who are here, we are like a family. Aziz Saab has come all the way from America. We have been interacting regularly on various aspects at various forums. And thank you very much for being part of this activity. And once again, thank you very much, Mahmood Saab. The few years back, couple of years back, when we met first time here in the same auditorium, you had promised that you want to see and you would like to see and you would like to build a gastroenterology unit in my hospital. I can see that the things are moving in the right direction. I've been told that a ward has been allocated. We are waiting for the dedicated faculty. We're waiting for the dedicated equipment. And I'm sure under your kind guidance and under your kind leadership, this vision is going to be achieved in near future. Um you are very close to the government, and I'm sure the effort required and the funding required for building up this kind of project, with your blessings and with your help, this is always achievable, and this will be achieved. Inshallah Ta'ala, I look forward seeing a beautiful gastroenterology unit in near future in King Edward Medical University and Mayo Hospital. Uh, and once again, as regards the students of King Edward Medical University and King Edward Medical College, I keep calling college because for me it's still a college. But now I understand it's a university. The students of King Edward Medical University and public medical colleges, they're brilliant. They're far, far ahead of other institutions. They're no less than any other medical college. And the kind of peer pressure that they have, this is not there in many other institutions. They always excel. And that gets reflected in the number of people who do post-graduation, irrespective of whether they do it in college physician surgeons here in Pakistan, or maybe Royal Colleges, Australian colleges, or American colleges. That's in big percentage. And they're there almost everywhere in the world. Wherever you go, the alumni of King Edward Medical College or University is there. And I look forward towards a close interaction with APGNA, with people sitting in UK, and similarly people sitting in Australia, who will like to pay back to their own institution. And once this platform is there, I'm sure they'll like to contribute more by coming back in big numbers, staying here as on sabbatical, or coming here as visiting professorship. I'm sure Professor Mahmood Ayaz will like to extend this visiting professorship to all the people, all the expert people who are working in UK or USA and other places in the world, so that they may come back to their own alma mater and contribute towards the development of the younger students. So thank you very much, Professor Mahmood Ayaz, for giving us the platform, for giving us the opportunity, and I look forward to a big future in gastroenterology in Mayo Hospital. Thank you.
Sir, now I invite Professor Wasim Aziz. The थोड़े से comments हो जाएं सर आपके.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. I think it's my third or fourth visit here, and it's always Dr. Ayasab is always here whenever we conduct the workshops, and under the guidance of Dr. Isar, Dr. Hassan, and other faculty members. Every year I'm seeing increase in the number of cases, the complex cases, and the advanced endoscopy going forward. So we're thankful to all the faculty members and Professor Saab and the VC Saab to guide us and get us to the next level. And we are committed from the APGNA standpoint and from the KEMCANA faculty members. We are really committed to help as much as we can, either in person or remotely, and we continuously help them with some supplies whenever they are needed. And I have a big stash of supplies at my home, so whenever somebody needs it, they are welcome to come and get them. Thank you.
लास्ट टाइम मैं जब अमेरिका में था पिछले महीने, तो सर ने मुझे एक इतना बड़ा सूटकेस किया जिसको कस्टम क्लियरेंस कराते हुए फिर मुझे कुछ स्ट्रिंग्स हलानी पड़ी. थैंक यू.
Last time I was here, so alhamdulillah, I have never had any problems with the customs. But, so don't worry, I still have connection, so I can make a call.
Now I invite Vice Chancellor King Edward University, Professor Mahmood Ayaz. Sir, aap.
Thank you. Bismillah ar-Rahman. Can you hear me without the mic? Yes, so thank you very much for asking me to be here. पहली बात तो जो है मुझे आज आके अंदाज़ा हुआ है कि जो पहले कभी नहीं था हुआ कि हमें जो है ना अब बड़े ऑडिटोरियम की ज़रूरत है ना, क्यों हाँ, अब जो है ना अंदाज़ा हुआ है मुझे कि इस जगह को थोड़ा-सा और बड़ा और वसी करने की ज़रूरत है कि ताकि सब लोग बैठ के जो है ना इस्तिफ़ादा हासिल कर सकें। सो I'll start my talk by saying Assalamu alaikum to you. So thank you very much for asking me to be here today. And what a pleasure and delight to be here and see this department growing, in मैं सही नहीं इसको steps में नहीं जा रहा, in leaps and bounds. And it's not only the gastroenterology department of North Medical, but the whole department of medicine, because they're all contributed to the efforts. The way this department of medicine is actually coming up. When I came here, it was very surprising for me that the King Edward Medical University, out of 4 departments of medicine, 3 were vacant and nobody was willing to come. तो उसमें सबसे पहले मैंने फिर दरख्वास्त की इसरार साहब से, ये कहीं इधर उधर कोशिश कर रहे थे जाने की, मैंने इनसे दरख्वास्त की कि मैं कहा जी मेहरबानी करें। मैंने गयास से प्रेशर पर डलवाया कि नहीं इनको यहाँ पे आके ज्वाइन करें, फिर इमरान से ज़बरदस्ती की, फिर दूसरे इमरान से। सो नाउ वी आर वेरी वेल प्लेस्ड, और बाकी हमारी बाकी फैकल्टी मैम के आने के, मैम समीना के आने से बहुत इम्प्रूव हो गई है और बहुत अच्छा हो गया है। मैं एक दो बातें आपसे ज़रूर करना चाहूँगा इस सारी चीज़ों के बारे में। पहली बात तो मैं ये करना चाहूँगा कि वंस अगेन व्हाट अ प्लेजर एंड डिलाइट टू सी रियास वंस अगेन। रियास ने बता तो दिया है कि there were 2 very dynamic units when we were doing our training over here. एक साउथ सर्जिकल यूनिट था जहाँ पे मेरे प्रोफेसर ज़फरुल्लाह चौधरी, ही वाज अप टू इनटू ऑलवेज इनटू न्यू थिंग्स, नई चीज़ों के बारे में कर रहे होते थे। और बिल्कुल साथ ही नीचे रियास साहब थे, वहाँ पे रजिस्ट्रार थे और ईस्ट मेडिकल में थे, और ईस्ट मेडिकल रजिस्ट्रार होना तो बहुत बड़ी बात होती थी। और मैं हमेशा इनको देखा करता क्योंकि हम सेशन फेलो ज़रूर थे लेकिन हम क्लास फेलोज नहीं थे। तो मैं इनको देख के हमेशा एडमायर किया था कि कितना खूबसूरत नौजवान, कितना एनर्जेटिक आदमी है, काश मैं इनकी तरह का बन सकता। तो कोशिश मेरी अभी भी पूरी चल रही है कि मैं इनकी तरह का बन सकूं, लेकिन मैं इनकी तरह बन नहीं सकता। मैं उसकी वजह आपको बताता हूँ। मुझे कल ही शिद्दत से एहसास हुआ। उसकी वजह है कि देयर वाज अ पेशेंट हु वाज फ्रॉम यूएसए, नदीम अकबर उनका नाम था। ही हैड एन अटैक ऑफ एक्यूट पेनक्रेटाइटिस इन यूएसए, और वो वहाँ पे ना बड़ी तकलीफ में वो वहाँ पे रहा। ये मार्च 2025 की बात है। 3 दफ़ा उसकी ERCPs हुई, 3 दफ़ा स्टेंटिंग हुई, 2 दफ़ा निकले, फिर दोबारा डाला। तो कलेक्टिवली आपको याद आ गया होगा मरीज नदीम अकबर। तो 5 दफ़ा उसकी ERCPs हुई। आखिरी मरतबा स्टेंट भी डाला, और स्टेंट डालने के बाद स्टोन्स वहीं के वहीं छोड़ दिए। और आखिर में चूंकि वो उसको बार बार तकलीफ होती थी, उसके वहाँ पे सर्जन ने कहा कि तुम इस तरह करो कि तुम पाकिस्तान चले जाओ, वहाँ पे जाके किसी को दिखा देना। जान छुड़ाई उन्होंने अपनी वहाँ पे। खैर वो अक्टूबर में यहाँ पर पाकिस्तान में आए, उन्होंने मुझे दिखाया। तो मैंने कहा देखिए, जब उनकी प्रीलिमिनरी इन्वेस्टिगेशंस की तो मैंने कहा, मेरे किसी रेफरेंस से मेरे पास आए थे, तो मैंने उनको कहा, मैंने कहा ये देखें, ये तो स्टोन्स आपके वहीं के वहीं पड़े हुए हैं। जो ERCPs हैं उसमें उन्होंने स्टोन एक्सट्रैक्शन का तो कोई जिक्र नहीं किया, स्टेंट्स डालने का अलबत्ता जिक्र किया हुआ है। खैर फिर मैंने गयास साहब से रब्ता कायम किया और मैंने इनको फ़ोन पे मैसेज भेजा कि गयास एक पेशेंट है, तो ये आपने इनको देखना है, तो हेल्प आउट करें मुझे। तो इनका छोटा सा हमेशा जवाब आता था, उसमें लिखा था सेंड, बस इतना ही, खाली ये लिखते खाली सेंड, बस इतना। मुझे पता होता है कि ये आजिज़ मरीज, क्योंकि बिजी बहुत है, तो इनके पास तो टाइम मिलना बड़ा मुश्किल है। तो वो जवाब भी उतना ही मुख्तसर होता है जितना इनके पास टाइम अवेलेबल होता है। उसमें लिखा था सेंड, मैंने इनको भेज दिया। एंड 3 days बैक दिस पेशेंट केम बैक वेरी हैप्पी। मैंने कहा जी मेरे तो स्टोन्स भी निकल गए हैं, मैं कंफर्टेबल भी बहुत हो गया हूँ। मैं तो कभी इस तरह फील ही नहीं किया अमेरिका में जब मैं अपना इलाज करा रहा था। कमाल आदमी के पास आपने भेजा है। और सबसे बड़ी बात है, डॉक्टर साहब ने स्टेंट वापस क्यों नहीं डाला? मैं कहा यार, अब 5 स्टेंट काफ़ी नहीं थे आपको, मतलब आप छठा आप दोबारा डलवाना चाहिए। उन्होंने महसूस किया होगा कि नहीं डलना। सो ओनली येस्टरडे आई डिड हिज रोबोटिक कोलिस्टेक्टमी। इट वाज वेरी डिफिकल्ट केस, बट जब मैं कर रहा था तभी मैं आप ही को एडमायर कर रहा था। तो मेरी अभी भी ख्वाहिश है कि अगर मैं आपकी तरह बन जाऊँ तो मैं बेहतर हो सकता हूँ। सो और ये इस चीज़ की गमाजत है कि आपके बेशतर स्टूडेंट्स यहाँ पर आज बैठे हुए हैं और सब आपको बड़े अच्छे अल्फाज से जानते हैं। सो थैंक यू वेरी मच फॉर बीइंग हियर टुडे। और आज जो आने का वर्कशॉप, जिसको मैं देख के बहुत मुतासिर हुआ, मेरा ख्याल था कि मुझे जो भी टाइम मिले मुझे यहाँ पर आना चाहिए और आपसे बात जरूर करनी चाहिए। ये मुझे लेसन दिया मेरे एक रेजिडेंट ने, उसका नाम है सानुल्लाह खान गिलजई। ही वाज फ्रॉम बलूचिस्तान, और वो अब जाके सिब्बी मेडिकल कॉलेज में जाके तो अपना काम करते हैं। ही इज अ वाइस प्रिंसिपल ओवर देयर। सबसे हॉस्पिटल में मेरे पास ट्रेनिंग के लिए आए, तो मैं उस ज़माने में बड़ी एडवांस लैप्रोस्कोपिक सर्जरीज करनी शुरू कर दी हुई थी। मैं यही laparoscopic myotomy और laparoscopic dilectomies और splenectomies, और मैं बहुत उसमें काम कर रहा था, distal pancreatitis सारा उसमें काम कर रहा था। तो एक दिन एहसान साहब मेरे पास आए, कहते हैं कि he is a Pashtun, resides in बलूचिस्तान। तो मुझे कहते हैं कि डॉक्टर साहब आप बड़ा डॉक्टर है, बहुत अच्छा ऑपरेशन करता है, बड़ा ऑपरेशन करता है और बड़ा काबिल आदमी है। मैं बड़ा खुश, मैंने कहा यार तारीफ कर रहे हैं, सानुल्लाह खान गिलजी पठान आम तो पे तारीफ कम ही करते हैं। तो मैंने कहा कि हाँ, मैं कहा हाँ साहब बड़ा आप ठीक कह रहे हैं। मैं कहा पर हमारा एक मसला है। मैंने कहा तो आपका क्या मसला है? आप कहते हैं आपको सब कुछ आता है, आपके पास बड़ा डिग्री है, पर मुझे क्या फायदा इसका? क्या आपका बड़ा नाम है, आप बड़े ऑपरेशंस करते हैं और आप जो है ना ये आपके पास इतनी डिग्री है, पर मुझे इसका क्या फायदा है? मैं कहा आपको क्या फायदा है? कहता हमको सिखाओ। वो तो मतलब वहां पे मुझे अंदाजा हुआ है कि द रेजिडेंट्स हु कम टू एक्चुअली train with us, they are not interested at all in what kind of expertise which we have, what kind of degrees which we hold, हम कितने बड़े प्रोफेसर हैं, उनको बिल्कुल से कोई गर्ज नहीं होता। वो कहते हैं हमने इसने हमें सिखाना क्या है, इस सिखाएगा हमें क्या? उसने कहा हमको सिखाओ। अच्छा, मैंने कहा यार ये तो अब क्या करूँ इसका? वो तो आई स्टार्टेड द फंडामेंटल्स ऑफ लैप्रोस्कोपिक सर्जरी का कोर्स। वो कहता था मुझे नहीं बड़ा ऑपरेशन करना, मैं छोटा सिखाओ और मुझे जो है ना लैप्रोस्कोप सिखाओ कैसा करते हैं, और बलूचिस्तान में नहीं होता मैं जाके करूंगा, और मुझे अपेंडिक्स सिखाओ, मुझे हर्निया सिखाओ, मुझे पित्ता सिखाओ, मुझे जो है ना ये सिखाओ, मुझे बड़ा नहीं चाहिए, मैंने वहां पे जाके बड़े ऑपरेशंस नहीं करने हैं, तो मुझे ये सिखाओ। तो हमने वो शुरू कराया फंडामेंटल्स ऑफ लैप्रोस्कोपिक सर्जरी। इट वाज वेरी पॉपुलर, पीपल लर्न फ्रॉम दैट, बिकॉज जब आप सिमुलेटेड ट्रेनिंग कर रहे होते हैं सिमुलेटर्स के ऊपर, और आज मुझे पता चला कि आप सिमुलेटर्स पे ट्रेनिंग करा रहे हैं, तो मैं इसलिए भागा चला है। मैं कहा जो भी कमिटमेंट है मैं आज आके बात जरूर करूंगा, क्योंकि मुझे बार इसानुल्लाह खान गिलजी याद आ रहा था बार। और नाउ ही इज द मोस्ट फेमस लैप्रोस्कोपिक सर्जन इन होल ऑफ बलूचिस्तान, चाहे वो सिब्बी से लेके खुजदार के दरमियान क्वेटा और ज़ियारत, वहाँ पे उसका बड़ा नाम है, हर जगह वो काम करता है। बट ही स्टार्टेड फ्रॉम दीज बेसिक कोर्सेज, सो आई एम वेरी इम्प्रेस्ड दैट यू हैव एक्चुअली स्टार्टेड दीज बेसिक सिमुलेटेड कोर्सेज के, या आप इनको सिखाएं कि ये छोटे काम कैसे कर रहे हैं। ये छोटे काम करने सीखेंगे, ये सीख जाएंगे, तो फिर आपका नाम भी होगा, आपका दवाम भी होगा, और आपका काम भी हर तरफ चमकेगा। सो दैट इज व्हाट द मैसेज इज, दैट वी शुड all of the consultants who are here, who are big names, जितने मैंने नाम में बारी नाम लिया, each and every one of you is very competent, very famous, but what about those people who are standing right at the back? ये सब लोग इस चीज के मुतमन्नी हैं कि हम इनको सिखाएंगे क्या, ये सीख के यहाँ से जाना चाहते हैं। और I really commend your department that you have established this course, and I'm sure that you are going to take up this course and move it forwards and make sure that these boys and girls, they learn what they want to learn. So thank you very much. Thank you. अब बैठे थे।
शील्ड्स लेनी है आपने, सर शील्ड्स डिस्ट्रीब्यूट करनी है। सर आप भी आ जाए सर इधर, शील्ड्स से सर आप से। अच्छा सर हाँ जी सर, now professor will seem to receive shield from VC साहब। For VC साहब by सर इमरान साहब, सर आपने VC साहब को सर शील्ड दे दी। So next case is fundal varix, and we are going to do injection sclerotherapy of fundal varix.
जी next case is patient Razia, 65-year female, presented with upper GI bleed. Patient is the case of DCLD due to chronic SCV. Endoscopy was done. We showed one column of low-grade esophageal varix plus medium-sized fundal varix. Now our plan is to inject the injection is to acryl. जी डॉक्टर शफकत,
we can see you and we can.
जी सर आपका ऑन कर
जी Dr. Hassan, can you hear me?
Yes, we can hear you.
So I guess the case has already been presented in the auditorium.
Yes, it has been presented.
So this lady presented with I guess hematomesis, and they found small size esophageal varices and GOV2 fundal varix. So you can see grade 2, one column of grade 2 varices. And when you are proceeding with a case of fundal varices, firstly, if previously endoscopy has already been done, you need to classify the varix according to Syrian class, whether this is isolated gastric varix 1, 2, or GOV type 1 or 2. Because in GOV type, gastroesophageal type 1, you can apply band, and if this is GOV type 2, that is along the fundus extension, along the fundus or isolated gastric varix 1. Both of these are now called cardiofundal varix because the management is different. And then if the patient has not bled, it is very important to get a cross-sectional image with a portal venous phase in each and every case and get a multidisciplinary approach where a hepatologist, endoscopist, and intervention radiologist will be giving their input, because the feeder vessels and anatomy of these varix may be very, very complex. So if you proceed, and if like in this case where the endoscopy has already been done and this is GOV type 2 fundal varix, then you need an adequate supply of needles, like 2 to 3 needles minimum, and then a good number of your histoacral. There are two types of tissue adhesives that you can use. One is N-butyl cyanoacrylate, and the other is 2-octyl cyanoacrylate. The difference is the 2-octyl cyanoacrylate, it comes with the name of dermabond. It's mostly used by dermatologists to close the skin wounds, and the polymerization time is a bit longer. Like in N-butyl, it's 5 to 7 seconds, and in 2-octyl, it's more than 10 seconds. You should be knowing all these important things. Yeah. So we are already in the stomach. And ideally, you and your assistant should be wearing goggles before you proceed with this procedure. Suction is not working.
Suction.
Please, suction. Water jet hai? Water jet. So what was the HB of this patient?
10.5.
So you can see two of them.
So
and on this varix you can see a punctum. So this one was bled, I guess.
So Dr. Shafqat, would you like to inject both of them separately, or just inject the single one, which you think is bleeding?
So there are two different. If there's a single large varix, a single injection may cover whole of the varix. But the important concept is you should not be injecting a larger volume. You should be injecting only 1 ml in 1 ml allocates, and yet you can always repeat the injection at different sites. So you will be injecting 1 ml and then reprobe the varix, and you can keep on injecting. There is no maximum volume that you can inject. You can inject large volume, but it's important that you should be injecting 1 ml per injection, and repeat injection after probing if there is any remnant soft area.
So in a varix like this, one varix, there is no red hue on the other varixes. So would you like to inject that in the same go as well, or you would like to wait for the first varix to settle down?
So the important thing is you can eradicate all the varices in the single session, and the other approach is you can obliterate the the culprit varix, and then you can always repeat endoscopy in like 2 to 4 weeks and then obliterate rest of the varices. 1 ml would be.
Dr. Shafkat, without any angiography and identifying the feeding vessel, where would you like to inject on endoscopic view?
Sorry?
Where would you like to inject endoscopic view? अगर आपके पास angiography में feeding vessel आपने नहीं identify की हुई.
Yeah, so that is the main advantage of the advent of EUS guided injection. With EUS guided injection, you can find the feeder vessel, and so with the identification of feeder vessels, the volume required to obliterate that varix will be smaller, and you can document the eradication of varix in the same index session, and you can, because along with glue we will be injecting coils, so the volume required will be less, and the chances of embolization will be less. So if we do not have the luxury of EUS, then you can inject. There are two school of thoughts. You can inject on the maximum bulge of the mound, and you can also inject close to the gastric mucosa where this varix is arising. So there is some data. If you inject close to the point where it's arising, the bleeding may be less. So there is some data on this. So all the instrumentation should be done with the straight scope. You see the scope should be straight, and your needle should, when your needle is just visible, you can do retroflexion.
So during this procedure, we're using a 21 gauge needle, and
yeah,
it's
with 6 millimeter.
With a 6 millimeter tip.
Yeah.
We're using the injections that is N-butyl cyanoacrylate injection, and we'd be giving the push with distilled water.
So the needle has already been primed with the distilled water. Distilled water, not the normal saline, should be used, because normal saline accelerates the polymerization of these tissue adhesives. So needle out. Inject. So after 1 ml of injection, a good part of injection would be in your needle. So you need to push. You need to wait for a few seconds, like 5-7 seconds, to allow the polymerization of your glue, and then you can come out. So some amount of bleeding is common, so you should not be going panic with this. In most of the cases, it will stop spontaneously. And if there is continuous bleeding, you can always give some tamponade with the blunt probe, and you can wait for a few seconds to allow the polymerization. If this is not stopping, then you can always re-inject. Yeah.
Assalamu alaikum. Shafkat, can you hear us?
Yeah.
Shafkat, we usually do in our practice that once we have injected, we'll pull the needle back and just keep pressing it for another 10 seconds. And that's what exactly you're doing now. But at the same time, after pulling the needle back, we'll just keep on pressing for 5 to 10 seconds. And then you won't have any bleeding. So that's what we usually do in our practice. So that is something that juniors can try as well.
Yeah.
That is a good strategy to have, and of course the problem with that sometimes is that your needle can get stuck.
The polymerization has happened and the bleeding has stopped. So there is no bleeding, and you see the varix has hardened. Yeah, this part of varix. Yeah. ये भी hard हुआ हुआ थोड़ा. नहीं ये hard है, slip होगा यहाँ से. You can. Okay, देख लेते. यहाँ पे, yeah, this is soft.
Not
So you,
Shafqat, this is, I think this is soft and you can inject.
yeah. This one is soft. I'm re-injecting. Needle out. And you need to see whether your needle is patent or not. Here? एक दफा देख लो, check कर लो. Yeah.
So so I think we should change the needle. Yes.
So the important thing is you should be removing the needle while it's out. Clean कर ले.
There should be high level of suspicion that the needle has blocked after first injection, simply because once you have punctured it again, and then when you find out that the needle is actually blocked, then that could lead to trouble.
Needle.
So as Dr. Shafqat said, you should have at least 2 to 3 needles ready when you are dealing with the case of hysterectal injection or a fundal varix. Again, you never know what you're going to deal with. Good.
Just needle out. Deep.
Beautiful.
Needle back. So I will wait for few seconds. No, mucosal, it's mucosal. So some ooze can be there. Oh, sorry.
So sir, how much suction do you do during this procedure?
So you should not be suctioning during these procedures because you can block the channel if there's actually the dye has come out of the varix, then you can always block your scope. So there is no bleeding. You can see the varix has hardened. Any question?
Dr. Shafqat, if it's a rebleeding occurs from the fundal varices while you are injecting or you have a bleeding and your needle is blocked, is there any backup for you there in endoscopy room?
So you should always have Sangsecond tube in your room, and the other important thing is if you have EUS scope do not need any endoscopic visualization of the varix. So if there is massive bleed or you encounter active fundal varix bleed and you have a EUS scope, you can always find the feeder or the bunch of the varices and you can inject on EUS view. There is no need for any endoscopic view. So that is the advantage of, that is also another advantage of EUS scope.
So we should have at the beginning centers who are at the beginning should have Sanks taken in the back.
Yeah. So if you do not have EUS, it's very important to have Sanks taken in any case if you're dealing with a case of variceal bleeding like gastric or esophageal varices. At times, in odd time, patient may be presenting with shock and massive bleed. So it's very important to have Sanks taken black tube in your department to act as a temporizing measure, like 12 24 hours till you go for definitive therapy.
And definitely you should have ample supply of hysterectal injections and needles, so you can inject at different points, which is going to be your first backup. And then of course there are sine second tubes and EUS needles.
And another important point is, as I already told before start of this procedure, it's very important to go for cross-sectional image in each and every case. We are not done with the definitive management of this case. We need to see the afferent and efferent vessels, the anatomy of this varix. So if there is a major shunt, like gastrorenal shunt, this patient may be needing Berto, or if the patient is having other complications of portal hypertension made in the form of ascites, you may also consider TIPS. So each and every case should be done in multidisciplinary setting. This should be discussed in multidisciplinary setting, and cross-sectional image with the portal venous phase is very important when you are dealing with the case of gastric varices. Thank you.
Okay, thank you.
very much.
Thank you so
Dr.
much.
Shafkat, we are shifting to other room.
This patient is Hanifa, 65 years old female, presented with on-off abdominal pain, vomiting, and yellow discoloration of sclera for last 9 months. And she was admitted 15 days back for the episode of acute biliary pancreatitis. And 8 days back, she discharged from the ward. And now she is symptoms free. Her LFTs are bilirubin is 0.4, ALT 33, AST 29. LFTs are normal. And her recent MRCP showed multiple GB stones, multiple filling defects in the proximal, middle, and distal CBD. Largest stone was measuring of about 6 mm with CBD of 8 millimeter, with mild dilatation of intrahepatic biliary channels. So we are going to do ERCP and stone extraction.
Okay, so we have already introduced a scope into the descending duodenum. This is a side viewing scope by Fujifilm, and we can see the ampulla in the right half of the screen. And before doing the cannulation, we should be inspecting the papilla closely to assess the level of difficulty while doing the cannulation. So the classic ampulla is easier to change karna. Okay, the classic type 1 ampulla is relatively easier to do the cannulation. Type 2 papilla is relatively flat and it has high rate of post ERCP pancreatitis compared to the rest of the papilla. This papilla is somewhat creased. We can see the number of creases on the infundibular portion of ampulla. So before doing the cannulation, we should be closely inspecting the papilla about the type, the level of difficulty, the kind of post ERCP pancreatitis expected. So we can see nicely the papillary orifice, and our purpose is to do the biliary cannulation. For biliary cannulation, we need to orient our papillotome toward 11 o'clock position, and we need to orient our papillotome in upward direction. For pancreatic cannulation, usually we aim at 2 o'clock, 1 o'clock position, and we need to go in the horizontal direction compared to biliary cannulation. So I think our position is quite comfortable. I aim at the outer margin of papilla. I bend it a little bit, bring the scope a little bit back, and try the guide wire there. थोड़ी सी wire try करें. Fluoro दिखाना है. Fluoro. Okay, so guide wire has gone somewhere. So yes, fluoro को image दिखाएं. And on fluoroscopy image, I can appreciate the guide wire is going toward the biliary. Fluoro दिखाएं. Can you guys see the fluoroscopic image?
Yes, we can see.
Okay, so my
Excellent
guide,
cannulation.
right, so my guide wire is in the biliary tree. I advanced the cannula further, and one thing very important, if the patient has small stones on previous MR, we should थोड़ा सा ऊपर ले जाएं. We should go at least to the level of common periduct before injecting the contrast, because the small stones, they at times get dislodged inside the intrahepatic biliary channel, and they are very difficult to be removed without a spy scope. Inject करें. Inject. So while Johanna is injecting, I am bringing the cannula backward. Inject, keep injecting. We can see some small floating stone. Hold on. So the patient has at least one floating stone, maybe more. And now we are going to do the sphincterotomy. For the sphincterotomy, I bring the cannula out, and for this cannula has the proximal portion that is insulated, so there is hardly any chance of injury to the mucosa. So I ask my technician to bow it a little bit, thoda sa bow kare. So we cut with the help of tip of the papillotome, usually 3 millimeter of papillotome inside the papilla is sufficient to do the cutting, and the direction is cutting toward CBD, that is 11 o'clock position. So we cut in increments. We should not be doing the zipper cut. And for sphincterotomy, we use the blended current, that is mixture of cutting and coagulation. So it's more of cutting, less of coagulation.
What is the current setting for the sphincterotomy in this case or in generally?
Okay, so the latest RB machines we use endocut eye, in which the basically the machine automatically senses the tissue density, and it can change the current setting automatically. And it is basically 313. I mean, it cuts for 3 seconds, then there is an interval of 3 seconds, 1 second. So this machine is RB 200, and we are using cutting and coagulation at 35 watts. So can you guys see the endoscopic image as well?
Yes.
Okay, so we are going to do the sphincterotomy, and for sphincterotomy we need to bowl the papillotome a little bit. Usually 2 to 3 millimeter of papillotome inside the papilla is required. We should be doing the cutting in the increments, not in zipper cut fashion. And I will be doing the cutting in the direction of CBD, that is 11 o'clock position. So we are right now in the perfect position to start our cutting. यार इसकी कोई अटैचमेंट ठीक है?
हाँ, इस पे कोई टेप लगा दें, इस पे कोई टेप शिप लगा दें।
ये पीछे कौन है? मुस्तफा, चलो स्टार्ट करिए। अटैच है?
नहीं।
Okay, so there is some issue with the cautery settings. It is doing more of coagulation, less of cutting. So we are trying different current settings. Dr. Hassan, what are your current settings for
Sir, we use 70 to 80 watts.
Okay.
For cutting.
Okay. 70 पे ले जाओ यार. Okay.
And for coagulation?
Huh? And what about coagulation?
Sir, we don't set any coagulation. Even 15 watt is good.
Okay, so we're using 10 watts of coagulation and 70 watts of cutting. Let's try. Now it's better.
30 watt is too little for this cautery.
Okay. So while doing the sphincterotomy, we need to adjust our scope position so that we might not be doing the eccentric cutting. And the length of cutting is really dependent upon balloon. You are not. Fluoro. Okay. You are not. Balloon पे आओ. खींचो ना बाहर. यार इसको जरा इमेज को सेंटर में करें जरा थोड़ा.
ऐसे कह रहे हैं कि टिप भी
बस
नजर आए,
ठीक है, इतना काफी
टिप
इतना।
नजर आनी चाहिए।
हाँ, थोड़ा सा और अगर नीचे ले जाओ टिप तक।
सॉरी
बस ठीक। दूसरी तरफ। हाँ।
So you are doing a balloon trial now?
Yes. So we have done the sphincterotomy, and we have almost completely cut the muscle. And now I start doing the balloon trawling. And for balloon trawling, we should inflate the balloon to the size of the duct, number one. Number two, we start balloon inflation in the lower third first. We should clear the duct from distal to proximal. Balloon up. We can see that one of the stone
has
been-
come out.
Yes. So we push the scope a little bit.
It's a yellow
down.
colored stone. It's probably a cholesterol stone.
ओके थोड़ा सा ऊपर जाने दो चले चलो बलून आप
ये भी बता दें कितने पे कर रहे हैं आप
okay down. So one need to be very gentle while doing the balloon trawling, because many of the perforations they happen while we are doing the balloon trawling, especially if we are not in the line of CBD. खींचो जरा
अब अच्छा
खींचो बाहर खींच
अच्छा सा occlusion
हाँ वो लेते हैं ऊपर जाने दो ऊपर जाने दो ऊपर जाने दो ऊपर ले जा आप डाउन चलो एक occlusion लेते हैं ऊपर चल के खींचो 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 ऊपर ले जा ओके बलून आप बाहर बेशक रहने दे अंदर ही Dr. Hassan, can you see us?
Sir, we can hear you,
Okay.
but our display is coming slowly.
Okay, okay. I just
because
wait.
We had a
So,
power failure.
We have cleared the duct. There is no further stone. It was only one floating stone. So to confirm that whether we have cleared the duct or not, we are going to take occlusion cholangiogram. For occlusion
Okay.
cholangiogram, we bring the stone extraction balloon till the level of proximal CBD, that is common hepatic duct. We inflate the balloon and we start slowly injecting, and in the live image we will be seeing whether there is any filling defect or not. Fluoro on.
Okay, so we
Inject.
need fluoroscopic view. Cameraman to please focus on fluoro.
Inject.
while injecting contrast
Inject. Can you see the fluoroscopic image?
Yes,
Inject,
we can
inject.
see. Can you enlarge the fluoro image?
Inject, inject, inject. Keep injecting.
Yes, we can see that the duct is clear.
Yes, we do not see any filling defect. Down. And once we have done the occlusion cholangiogram, we need to see whether the contrast is freely flowing out of CBD or not. We can apply the gentle suction, and we can see that this contrast is freely flowing with our gentle suction.
Yeah.
So with that, we finish with the procedure. We see whether there is any bleeding or not. A small venous ooze is common after balloon trawling. That should not be worrying much. It automatically stops in a while. We should be looking particularly for any perforation, for any arterial spurt, and I think we are done with the procedure. So before removing the scope, we need to unlock the wheels. In the stomach, we have to do the suction of any fluid or air, and elevator should be up, and we gradually pull the scope out. There should not be any resistance in pulling the scope out.
Sir, nicely done.
Sir, can you hear me?
Yes, sir. I have displayed your slides.
yes can you hear me
Yes, sir. We can hear you.
okay
We have
perfect
got a couple of minutes in shifting to the next room.
sure
Sir,
so that's exactly
I am
what
showing your slide, which you have
That's
given
exactly
me.
what Dr. Riaz was talking about. The type 1 ampulla is normal ampulla. You go in, it's clear as day. You can see on the slide as well.
Yes.
Type 2
Yes, we can see on slide.
type 2 is known as a pinhole ampulla. and it's very, very difficult to get into it. Very high risk of pancreatitis and very high risk of failure. You can see that on the slide.
Yes, we can see on the slide.
And then type 3 is the one which is elephant trunk ampulla, where you can see that it's extremely long and the ampulla is facing the other way. So that they are the ones which are quite tricky, and you can see that the failure rate is quite high in those as well.
Yes,
And
failure rate
type
is 11%.
Yes, and type 4 are the ones which are hidden under the folds. So the one we saw today was a mixture of type 3 and type 4. So less type 3 and more type 4 because it was hidden between the folds. So we had to uncover the folds. I'm not sure if you missed that part because the light was gone for a while.
We had seen that.
You saw that part. So we had to remove 2 folds and then the ampulla became clear. So it fits with type 4, but then the long trunk makes it a bit of type 3. So it was a mixture of type 3 and 4. But Dr. Riaz did a very good job. First time cannulation. So excellently done, mashallah.
And so pancreatitis rate is also high in type 1 and type 2 papilla. It's more in the type 2 papilla, almost 20%.
Yes, because of the tightness of the ampulla. Because what tends to happen is when we're trying, if there is a stone at the bottom of the bile duct, and that is your primary purpose of ERCP, your tome will hit the stone or the wire will hit the stone and go into the pancreas.
So type 2 is the most difficult. It has got cannulation failure rate of 12%.
Yes.
Difficult cannulation 52%, pancreatitis 20%. So what are the tips and tricks to negotiate type 2 papilla?
Yes, so we can use a tapered tip cannula to get into it.
Okay.
And use a narrow wire like a 0.025 wire or a 0.018 mm wire. So these are the 2 things that I tend to normally do in my clinical practice. Otherwise, you can use pre-cut sphincterotomy. So just place your pre-cut sphincterotomy's needle at the top of the opening and go above as much as you can easily. That can cause a bit of bleeding. So far, if I've done it in, let's say, 100 cases, maybe 5 have bled. So it's not a major issue. The idea is to open it up. As soon as it opens up, then CBD entry is actually much easier. So 3 tips. Use a tapered tip cannula. Use a smaller wire, 0.025 or 0.018. And number 3, use pre-cut as the last resort.
Sometimes it happens that wire goes in, but sphincterotomy is not going inside. Then what to do?
In that case, we obviously should have done a pre-cut. So leave the wire in, come out, go in with a pre-cut and just cut it and then just go in. That's why we do the pre-cut first. We don't put the wire in, but you are right. If you have used a smaller wire, but your tome is a normal size, the tome will never go in. And that's why we need the pre-cut. However, what you can do is, if your tip, it depends on the type of tome you are using, because different companies have different tomes. If you are using a long nose tip, cannula, you can insert it as far as it goes, and if the blade, the cutting blade, touches the ampullary opening, the papilla, you can cut it as far as you can go. That's a sphincterotomy. It's as good as a sphincterotomy.
Okay. So I have done this several times and found this trick helpful.
Yes, that's what I do. So I just go as close as possible. And if I am luckily using a small tip and a narrow nose sphincterotome, I just do a cut as far as I can go.
So any details about the case which you were discussing that you had found difficulty in cannulating? What was that case? And
that was an elephant trunk one, but that patient had a 12 millimeter stone at the bottom of the CBD. So every time I went, this was 3 or 4 days ago. So every time I went in, the wire would go into the PD. So I put a PD stent, and instead of doing a pre-cut at the ampulla, I went to the, since it was a very long and angulated ampulla, ampullary complex, the patient doesn't need to be here. If you want to remove the patient doesn't need to be here. So you can remove the patient. Thank you.
Okay, sir. Thank you. Session one is ready.
So I just
Thank you, Dr. Fahad. It's Dr. Ahmed here from PKLI. In our practice, usually in type 2 and 3, because we know there's a high, it's a very difficult cannulation with a high failure rate. So we switch early to needle knife. That's what we do. Instead of, if we keep on trying and then we know there'll be edema and swelling of the ampulla with more chances of failure. So nowadays we switch early to needle knife, and that reduces the risk of pancreatitis as well.
So now we have switched to room number 2, where Dr. Hamad is ready with the polypectomy case. Another polypectomy.
Yes, this is a case of RH 6-year male presented with bleeding PR for 2 weeks. Sigmoidoscopy showed 1 centimeter rectal polyp. Plan is for polypectomy. Dr. Hamad is proceeding with the procedure.
Can you hear me? Can you hear me? Can you hear me now?
Yes, sir. We can hear you, Dr. Hamad.
Excellent. Finally. Okay. So this is the polyp, and looking at it, looks like inflammatory hematomatous type polyp. So we are using a new endoscopy system called Sonoscape.
Can you show NBI or some contrast enhanced
Number 3.
endoscopy on this system?
Okay. So that's the narrow band.
So what is it called on this system? NBI or something else?
Yeah. Well, what's the? Do you call it narrow band imaging or some other? Is there a different name? It's equivalent to narrow band. Okay. So what we're gonna do? We're gonna inject at the base. It's about a centimeter polyp. Quite a size for this 6 years old chap. Okay. So injection needle. So I can just inject saline. Maybe with some blue color, indigo carmine or methylene blue. I don't use adrenaline as such. Because if there is some bleeding, I want to see it now rather than receiving a phone call sometime in the middle of night.
So we have got some lifting agent.
Yeah. Is there a particular pre-filled lifting
Yes.
agent that you have available?
Yes, yes. It's
Are we
available.
going to use that now? ये कौन सा lifting mix है जी? Okay, ये आपने खुद बनाया है?
ये
Okay, so
बना बनाया
this is the pre-filled. Nice. So इसके ingredients क्या हैं किस composition में जी?
इसके ऊपर से देख के बता दें.
Okay,
Dr.
so
Habib, आप
we are
बता दें.
using just so you know, we are using an adult gastroscope, so you can see where this needle is coming from as compared to if you were using a colonoscope. So आपको you need to know your tools, your gadgets. So this is a pediatric gastroscope. This is an adult gastroscope rather than a pediatric colonoscope. So needle out. Yeah, needle out. Okay, inject. Okay, keep going. Keep going. Keep going. Yeah, keep going.
So a nice lift.
Okay, stop needle back. Okay, so we've got a nice lift here. I wonder if I should inject on the other side a little bit, just to make it pretty. Otherwise, for the sake of removal of this polyp, that probably isn't necessary. Let's inject a little more. Okay, maybe we are okay. Okay, so one way of doing it, is to just go, any injection is to just go with the needle back in, touch the area and open the needle, and that will just go inside the submucosal space. Needle out. inject. You just need one. I'm just not showing it very nicely. Yeah. So the ideal is just one injection. Sometimes you need more. Okay. जितने आप सुराख करेंगे उतना में से लीक हो जाएगा वो बाहर.
So, Dr. Hamad, you don't mix adrenaline in the lifting solution?
I don't anymore. As I say, my rationale is to see whatever bleeding has to happen now, rather than once the vasoconstriction of the adrenaline has gone out, then some later delayed bleeding. And also, I have injected a few. Okay, we've got this snare. This is we have the Boston Scientific rotatable snare of
Dr. Hamad,
2
can you,
centimeter.
we are getting the image. We had a power failure.
Yeah.
Can you just wait a second?
Sure. Okay. Are you happy for me to proceed, Dr. Asen?
Just a second. Yes, we have got the image.
Okay, so once again, if you see, we are using an adult gastroscope. You can see the snare is not coming out from the place where you are used to see when you're, holding a colonoscope. And goodness.
Dr. Hamad, it's Dr. Fahad here. May I ask a question, please?
Please.
If you don't inject adrenaline pre-polypectomy because you think the patient might be later on, why not put a clip on them?
Open, please.
If
Open.
there's a high risk polyp.
Yeah. If there is, if you worry about a bleeding, as I say, I want to see it now, deal with it now, rather than deal with it later. So adrenaline, on occasions can mask. Dr. Hassan, can you hear us in the room?
Yes, we can hear you.
Can you see the screen as well?
The screen is just coming up.
Okay, sure.
Yeah. We can see TCL written on it.
Chale.
Please let us know if you can see the images so that we can. Yeah. Not yet?
Yes, we are back.
Okay, so open.
You can start.
Open snare. Open snare. Yeah. Okay, so this snare is a bit too large for the size of the polyp, and also it's not my favorite.
1 centimeter snare as well.
Okay. Well, we've opened one. नहीं अभी थोड़ा सा close.
Yes, we can hear you.
Okay, can you see the screen at all?
No, not
Okay,
yet.
so once we have आपने mark तो नहीं किया? Okay. So once you see the screen, please let us know. We have grabbed the polyp with the snare.
Just
we
give us a few seconds.
Yeah, that's okay. We're using the hot snare, of course, for this type of polyp.
So which snare size are you using?
So we had opened up 2 centimeter snare, so we're just continuing to use that, although that's a bit too, that was a bit too much for this one. But don't.
Whether you're going to go with cold polypectomy or hot polypectomy?
No. This is not one for cold. Rectum is highly vascular, as you know, and it's very rare that you would use. थोड़ा ढीला कर दें थोड़ा. It's very rare that you would use a cold. If this is very diminutive polyp and you want to just get rid of it.
Yes, we can now see.
Okay, so we're going to, I've lifted the polyp a little bit up, as you can see, and I'm, holding the snare at the back. So wait, आपने 3 पे काटना है. So इस तरह से होगा ये 1, 2, 3 इतना. ठीक है जी. So मैं किसी snare से किसी और side wall वगैरह को touch नहीं कर रहा, as you can see. Okay. So
Dr.
connected.
Ahmad, are you
Yep.
comfortable in the position of your snare? I mean, I can see some of the polyp inside.
Can
the
you?
snare.
Can
Yes.
you?
Yes.
Okay. So firstly, I'm not worried about the polyp anyway because it looks inflammatory rather
Yes,
than
yes.
or hematomatous. So even if I leave some behind, I'm not too bothered. That's one. Secondly, it was a very odd location, very mobile, and a relatively poor prep. We can open up a little. Thoda sa khole. Just and then we can go a little bit towards the base to try and grab it close.
Snare बहुत बड़ा है.
Close.
Snare
Enough.
बड़ा है मेरा.
Okay. So how about that? More or less same area, but I think I'm okay.
Okay. So you
Okay.
start cutting and then we can reevaluate.
Yeah. So I'm just gonna wait for the peristalsis to go away, and then we'll put some energy through it. Okay. So जैसे मैंने कहा था 3. Okay. So connected है जी ये. मुझे तो नहीं कोई यहाँ पे कोई हरकत महसूस हो रही. अल्लाह अकबर. Okay, wait करें अब peristalsis गुजर ले तो. So quite a few technical challenges, electricity and whatnot. Okay, so ready जी? Ready? Okay. तो अभी तक तो नहीं हो रही यार कोई cutting. So our diathermy is not working.
साथ वाले कमरे से ले हैं.
So it strangulated the polyp quite a bit. Allah.
Yes, Dr. Amir, can you present the case?
Yes, sir. Sir, we have a patient, Muhammad Ramzan, 53 years old male, presented with the complaint of dysphagia for 5 months with 20 kg weight loss. Can you hear me, sir?
Yes, we can hear
Yes,
you.
dysphagia and weight loss for about 5 months. His HB is 9.2, TLC is 15,000, platelets are normal, PTIN are normal. His CT scan showed asymmetrical mass-like thickening about 2 centimeter in the upper esophagus. We performed the endoscopy 5 days back that showed ulcerated friable polypoidal growth starting from hypopharynx and extending about
No, Imran bahar aa ja. Imran bahar aa ja. Imran bahar aa ja.
fast with maneuvering.
Bahar aa ja,
Stomach
bahar aa
and
ja, bahar aa
duodenum
ja,
were
bahar aa ja.
normal. So the plan is peg tube insertion.
So Dr. Imran.
Ambu de. Can you hear me, Dr. Hassan?
Yes, we can hear you.
So at the moment, patient is becoming hypoxic and tachycardic. So we have just paused the procedure, and anesthesia team is doing the suction. We started doing the procedure in the left lateral position because previously patient had the procedure 5 days ago, and it was quite difficult to pass the scope, although it went through with some maneuvering. So at the moment, anesthesia team is trying to stabilize the patient. So we're just waiting for that.
So I thought that you were able to pass the scope into the esophagus.
No, not at the moment because patient was desaturating and we just came out so that anesthesia team can stabilize the patient.
Okay, so we can shift to other room and
Sure.
we come back to you when the patient is stable.
Yes.
So Dr. Hamad, we are back to station
Yeah,
2.
can you hear me?
Yes.
Okay, so I'm in a bit of what is called a pickle. So while waiting for the diathermy, the strong peristaltic forces, they have taken the liberty of removing the polyp cold. Now I'm throwing some water there, trying to see the pedicle, the stalk, the base, in other words, and see if that is bleeding, whether we should put a clip on or no. And the peristalsis is now helping me. So अब पानी आ ही जा रहा है खुद ही. I don't know, the equipment is is just you know,
The equipment is not helping. Okay, so oh goodness, मेरे सारे trouser गीला हो गए. Right, so coming back, trying to find where we removed the polyp without our wish. So this is the stock. The polyp was removed on its own because we were waiting for a long time. It's not actively bleeding, but is oozing. And I do not know. Can you hear us?
Yes.
Okay. So I do not know how much is left, but I think if I grab the, yeah, so there's a bit of ooze there from the central vessel. Very odd location. Again, the rectal fold doesn't help. And then the sedated patients.
So what is your plan now? Do you want to
Yeah,
grab the rest of the stock and do
that-
a hot
Yeah.
polypectomy?
Well, the polypectomy has been done, but I want to do a stockectomy now. That will do two purposes. One, any residual polyp will be gone, and then the hemostasis will also be achieved. But what I want to do is to use a smaller snare. छोटा snare दें मुझे. और ये देखें पहले बाहर check करें कि अरबी चल भी रही है नहीं, because we are not still sure about the diathermy, whether that is working or not. And my other bailout plan is to put a clip on and come out, if you're happy with that.
So what?
इसको yeah.
So while we're waiting, why don't we go for an adrenaline injection?
Why? What would that achieve? Snare चाहिए मुझे.
Hemostasis.
So there is no active bleeding that is bothering me that I need to do something about it right now. Just to lend out for it to close properly. No. अपनी आप please मेरी instructions का wait करें. Open करें. Open. Okay. पूरा open है जी. Oh my God, this peristalsis. Two reasons. One is any residual polyp. Two is we discussed about clip, but then let's say the demand or for the sake of demonstration and making sure we do not leave any polyp behind. Okay. But we can clip it. Don't know where it is. खुला रहने दें, अंदर बंद नहीं करना ना. Where is it? That's the one. इधर hold करेंगे जरा. Please, यहाँ पे. Okay. Hold में. Hold है. Hold करें. Hold करें यहाँ पे. Okay. Close. Close तो हुआ नहीं. कोई resistance है आपके पास? I think that is slipped out. Okay, it's a very soft piece of tissue. God knows. Okay, just take that out. ये करें. Okay. They're ready for the next. Okay, so we'll just deal with it clinically and come out. Okay. Thank you. Okay, मुझे दे दें snare.
Okay, so I think whilst you were in room 2, our anesthesia team have stabilized the patient, and we also managed to go through that tumor in esophagus. Is also involving the hypopharynx as well. It's a quite large tumor. Biopsies have already been taken. CT scan has been done already, which is showing that it is a T3, N1 and M0 tumor. But patient is cachectic. I don't know if you can see the patient. And with dysphagia, we're planning to put in an PEG tube for feeding purposes.
So can you trans-illuminate clearly in this patient?
So we have a camera team here, and at the moment, can you see the trans-illumination?
Yes, we can see.
But
clearly.
that is really when we putting in a PEG tube. Usually, it has to be 2 centimeter below the xiphisternum and 2 centimeter medial to the costal margin. So this is quite far below actually. But if we come up towards the GOJ, Patient is desaturating again, so you guys just have to hold with us. Okay, we just want patient to stabilize before we can start the doing anything at the moment. Okay, that is one other concern we have, and we would like audience to comment on it. This patient, there is a mass which is involving the hypopharynx and the upper part of the esophagus. We went in with a lot of maneuvering. There was some resistance as well. Would it be safe to pull in the peg?
Not in this position. This is paraumbilical. You're most likely to go through the small bowel and then the stomach. So I wouldn't put a peg here. I think we need to go up a bit, close to the Ziphy sternum, and try there.
Okay. So I think we are done. This is the stock. Okay. Can you hear us? Can you watch our screen, guys, in the room? Open.
So we'll come back to GOJ and we'll show you where the transillumination is right at around 2 centimeter below the Ziphy sternum. So Imran, if you could pull back a little bit more. Can you guys see transillumination?
Yes, we can. Yes, we can.
Okay, but the only issue with this is slightly go inside that this is just very near to the GOJ. Okay, so there would be a lot more chances of, I think, complications if we try and access this area. What does the house think? Yes. Okay. So we have a sort of dilemma at the moment. If you could see on the camera where I'm pressing at the moment, it's quite probably near right iliac fossa, and you can see a good bulge in the stomach. But it's too, I think, too far down, and I'm not sure if there's any small bowel going to be in between the stomach and the skin. If we go higher up, which is just about 2 to 3 centimeter below the Ziphy sternum, then this area is just below the GOJ. So what does the house think? Shall we go for this area or shall, is anyone? So we need a suggestion and input from the house. What do they think? Shall we go for this area, which is near GOJ, but it's quite safe?
Sir, house is closed for right now, but I'll take an opinion from Dr. Fahad. Just a second, will let me show it on the screen.
Okay, thank you. And I will take an opinion from Dr. Fahad. But this is the only area then.
Dr. Fahad is on with you right now.
Gee, how can I help?
So Fahad, we are just asking for an opinion that in this patient, if you're able to see the transillumination, which is about 2 to 3 centimeter below Ziphy sternum.
Yes.
But when we are putting the digital pressure, this area which you can see on the scope is just near to GOJ. We don't have any other safe area because the other areas are near right iliac fossa, and we are not sure if there are any intervening small bowel. So what does the house think, that if we go ahead and put the peg near GOJ or we go for rig?
GOJ, I agree with you, it's too high up. There's a very high
Yes,
risk of
that's what I am saying as well.
very high risk of reflux and aspiration. I agree with you. But I think the other thing we could do is to deflate the stomach a bit as much as we can, and then retry transillumination close to the sternum and see if that brings us close to the body of the stomach.
Okay, we can try and do that. So just decompress the stomach and go near injcetion and try transillumination again.
And if you could turn the lights down a bit in the room. Or if not-
Okay, I think the major light is of the cameraman.
Right. Okay.
Go forward. Go forward.
Yeah, close to this wall. Yeah.
Okay, so we have this one area. I don't know if you can see the transillumination in the room.
We can't, but we can see that we can see the finger pressure very well.
So
and
here we can
it's-
have the transillumination, but the issue with this area is going to be when we inflate the stomach, then it's going to move. We have to inflate the stomach before we go in to make sure that it's just next to the wall.
Yes, but that won't change the location of the peg. I think. I mean, it's your call. You have the scope in your hand. It's different when
Pitya.
you have the scope in your hand and I'm just commentating. But you have the scope in your hand. If you feel it's unsafe,
I think I think I'll try in this area and let's see how we get on. Okay.
Just try with the green needle when you put the local anesthetic.
Yes, that's what I'm
Because
going to do.
That won't do much harm. Even if it goes through the colon, it won't do much harm. So,
Okay. Okay, so we have identified this area where the green needle went in very easily, like just 1 centimeter with the green needle. We are inside. So I have applied some lidocaine and I am just now giving a nick in the skin. If you guys can see that.
Yes, we can see.
But it's very skinny, guys. So there's no fat in there.
Yes.
So I'm going to go in with the trocar and needle. And can you see that coming in?
Yeah.
On the scope? Okay.
Yes.
There is some issue with the screen. So I'm just going to take the needle out now and push the trocar inside. Okay. So we are inside safely. Can you give him a snare? Okay, so now I'm going to put a wire inside and Dr. Imran is going to hold that with a snare.
Okay.
Okay, so the wire is inside. So first we'll go in with a snare. So Imran, open up the snare. So this we're just waiting for the snare to be in place before I can push in the wire. Yes. Is snare fully open? Yes, that's fine. That's fine. That's okay. So let me push the wire in and can you hold it tight with a snare now? Is it tight?
It's not tight. Not yet tight.
Okay.
Tighter.
That's fine.
Tighten
So
up.
now you.
Yes, now it's tight.
Okay, so now I'm going to pull it out. You have to pull it out with a scope, Nimran, now. So you have to come out with a scope. Hold this and come out with a scope, and I'm pushing it in.
Now cameraman should focus on Dr. Imran.
Okay, so there is some bleeding in here. It's probably because of the trauma to the tumor.
Yes. Yeah.
So I'm just feeding the wire in while Dr. Imran is coming out with a scope. And here you can see the tumor. The biopsies have already been taken. So we are not going to take any more biopsies today. So it's a quite long segment of tumor. And probably looks like with the involvement of hypopharynx and everything is not going to be resectable disease.
No.
Okay, so we are out now. So unfortunately in this case, we'll try if we can go again with the scope once the peg is in place. क्या हुआ है? अच्छा. So I have peg in my hand now and I'm going to make a knot with the peg. Can you guys see that? So I have made a knot with the peg.
I think the cameraman is not focusing on his hands.
Yeah, the lights are off, I think, still.
Please focus on the hands of the
camera. Lights are off.
So if you could see, I have made a knot with the PEG tube with the wire we inserted through this hole. Can we have some jelly, please?
Kindly put lots of jelly on the back bumper.
इसके ऊपर लगा दें चलें ठीक है कोई मसला नहीं now this is not sterile हाँ हाँ दोनों साइड पे लगा दें
Yes, now we can see that they are putting some jelly on the bumper
Yes.
of the PEG tube.
Okay.
Because it has to
So
pass
now
through
we
the
are going to, so Dr. Imran, you have to hold this straight. Hold this straight. Yes. So now I'm going to pull it inside with this wire. Yes. Okay, keep going, keep going. Patient is stable at the moment hemodynamically, so I'm not worried about that. So there is some resistance here. Yeah, that's fine. So I'm just going to extend the nick a bit. I just have to be careful because the stomach wall is right underneath it. I'm just going to extend the nick a little bit more so I can go in quite easily.
Please focus on the skin area where incision is being extended. And
Okay.
so the tube.
So the tube is going in now.
So I think it
Okay,
has
so
passed through the.
Just leave it at 4 centimeter. Please don't pull it.
Okay,
too much.
so tube is in and we are now at 1.5 centimeter mark. So Dr. Imran will go in again to make sure that it's in the right place.
Is there any need to go back again?
I don't think so. I'm quite happy with that and with his case because it was quite difficult to go in previously. I don't think so there is any need to go in. I'm more than happy because the marking is just at 1.5. So I'm more than happy to leave it over here and secure it over here.
We had a case back in the UK where the peg bumper was actually between the stomach and the skin. And it was being done by my consultant when I was a trainee about 15 years ago.
Sorry, we can't hear you very clearly. Can you repeat your remarks, please?
I'll speak up. Sorry, it's Fahad. So,
Yes, Fahad.
So yeah, we had a case where my consultant went back in, and the peg bumper was lying between the stomach and the skin. So he pulled so hard that the peg bumper actually came out into below the skin. So we had to obviously remove the peg, get the surgeons involved, and then get a new peg in done by the surgeons. So I would definitely go back in, takes 1 minute.
Thank you, Fahad. I didn't pull that hard, but still you made me worried now, and we're going to go back in again to make sure that we have seen it.
I'm sorry, that was not my intention. I apologize, but I'm just saying that since then I have made a practice that I always go back in and check.
I
the
think
bumper is flushing and it's working.
I think for juniors who are listening, this is an excellent tip that the best thing is to go back and be sure that the bumper is in place and we have successfully placed it.
They're all in agreement with you.
Position थोड़ी change करें. So we went in left lateral position. We have changed the position of the because as we mentioned earlier, it was a difficult intubation. I think you're in the right place. So Dr. Imran is going in with little bit of maneuvering, and I think we are in now. This is esophageal tumor. ठीक है, you're in the right place. हाँ, वो resistance होगी वहाँ पे थोड़ी सी. You're in the right place. The tumor over there. So yes, it's just there. Section. Come back and have a look again if you're not sure. Go back in again. So we are in. Okay, get him back straight. Huh? Bronchial side पीछे इमरान bronchial side है bronchial side है bronchial side है bronchial side है bronchial side है. हाँ, दूसरी साइड से जा. ऊपर से जा. हाँ ठीक है जाओ यहाँ से. यही एरिया है. हाँ ठीक, रेजिस्टेंस होगी, थोड़ी मैनूवरिंग करो. हाँ मैनूवरिंग कर थोड़ी सी. पल्स ऑक्सीमीटर यार देखना, इस हाथ पे लगा हुआ था. चला गया अंदर. हाँ ठीक है, यही है. So it's not an easy intubation by any means.
That's quite understandable, but he's doing a really good job with stable hands. So well done.
So I think it's just all the tumor invasion. I think you're at the right place, Dr. Imran.
So if you are having difficulty, then I think that there is no need to go in.
I think we'll just try one last time because Fahad got us worried. So if we can't, then obviously we'll just leave it at that.
I'm sorry, it's all based on an anecdote. I apologize if I got you worried too much.
I never had any of, or never actually read about any of that complication. But yes, all complications are possible when we are doing invasive procedures. So I think thank you for enlightening us. And
that's because we never published it.
हाँ ठीक है, यही जगह है, यही लग रहा है इमरान, यही जगह लग रही है. हाँ इधर से जाने था, ठीक है. हाँ ऊपर ही होगी ना, इधर ही होगी. हाँ ये ऊपर ही है, इधर ही है. That's fine.
I think that you're having again difficulty in going through the
Yes,
esophageal tumor.
I think we'll just
So,
leave it over there.
yes, I think that you should leave it there.
Okay. हाँ ठीक है काट लेगा बाद में
So well done.
Sorry Fahad, we couldn't see again inside, but I'm very confident that we didn't pull it too hard.
Yeah. Okay, so Dr. Ahmed and Dr. Imran, now you should come to second floor professor office.
Sure, we'll do.
Thank you.
Thank you.
So this
मुझे
brings us to the end of this workshop, and I am thankful to all of the faculty members who have come from different hospitals of Lahore and from USA. Thank you very much.